Hi, everyone. Good afternoon. We're just going to finish up lunch and get started, if that's okay. I'll have everyone can take dessert and get ready for our next session. Okay, thank you. So I want to introduce the next 4 speakers for our next panel. We're going to start with Tracy Vogel, is an obstetric anesthesiologist and director of the Perinatal Trauma-Informed Care Clinic. She speaks on the topic of birth trauma and the need for trauma awareness in obstetrics. Her hospital-based work includes creation of specific work plans for patients with prior sexual trauma, opioid tolerance and substance use disorders, and mental health concerns. Miranda Klassen is an assistant professor of anesthesiology at Harvard Medical School. She serves as program director for the regional anesthesiology at MJH. Her interests are lumbar thoracic neuraxial ultrasound and pain management in obstetric patients with opioid use disorders. Grace Lynn is professor and chief of OB and women's anesthesiology at the University of Pittsburgh. She is principal investigator of Elevate, an initiative aimed at optimizing anesthesia choices during cesarean delivery through patient-centered comparative effectiveness research. And Miranda Klassen is executive director of the Amniotic Fluid Embolism Foundation, which she founded in 2008 after surviving an AFE during childbirth. She co-leads the AFE registry, has published research on AFE support during and after severe maternal events. So we're going to have all 4 of those speakers. We'll start with Tracy, please. Thank you, all of you, for welcoming everyone.
Very much. Okay, welcome back from lunch, everyone. Hopefully you will stay awake at this time. This is not the best timing for a lecture. I'm going to do my best to stay at the podium. I usually walk around when I teach this type of topic, but I will do my best. I'd like to start off by saying it's always a privilege for me to stand up here and talk about this particular topic. It's a little bit different, I think, than what we've talked about so far, but it will have some crossover ideology, as you'll hear as I talk. I'm going to try to stay on time. I usually spend a whole day teaching about this. One of my functions is within our state quality collaborative, doing full-day trainings on trauma-informed care practices. So to give you just an introduction in about 18 minutes, as you've heard from other speakers, is incredibly difficult. But think of it as this introduction to what trauma-informed care practices look like, how can they be employed, and what's our role as obstetric anesthesiologists in bringing this into the patient experience. And just briefly, if anyone has any stress listening to any of this, because I know by statistics many of you out there come with your own histories of trauma, please take care of yourselves. Self-care, if you need to get up and leave, please do so. Come back when you feel like you want to, or you feel like you can. A focus today with trauma-informed care is that I want people to understand it is not just for people who've survived trauma. It can be used as a universal precaution, and I hope I can convince you of that as I go forward. Okay, as far as objectives, if you're not familiar with trauma-informed care, I will teach you about the 6 pillars that are at the core of implementing this type of care. I also want you to know that trauma-informed care is not a checkbox activity. You don't get to go home today saying, oh, check the box. I had a trauma-informed care lecture, I'm good to go. It is not like that. It's a cultural shift, and it takes time. Again, understanding this as a universal precaution and not something that is used exclusively for survivors of trauma. And then lastly, what is our role as obstetric anesthesiologists or anesthesia providers in this space? How can we prevent trauma? How can we prevent traumatization and re-traumatization? As far as disclosures, I own my own website where I post patient narratives. I also have a role in an AI company, but neither of my roles preclude me from delivering a very unbiased presentation today about trauma-informed care practices. So, to get started, I think it's important for people to understand what we're even talking about here. This is not necessarily physical trauma that we're talking about, it is psychological trauma, even though the two are often entwined. So I love this definition as a general concept of what psychological trauma is, and it comes from Judith Herman's work with rape survivors. And I want to share this with you, and as I read it, I want you to pay attention to specific words that I highlight. So psychological trauma is an affliction of the powerless, so it's powerlessness. At the moment of trauma, the victim is rendered helpless by overwhelming force. When the force is that of nature, we speak of disasters. When the force is that of other human beings, we speak of atrocities. Traumatic events overwhelm the ordinary systems of care that give people a sense of control, connection, and meaning. Control, connection, and meaning are taken from people during traumatic events. These events are extraordinary not because they occur rarely, but because they overwhelm human adaptations to life. They confront human beings with the extremities of helplessness and terror. Okay, so powerlessness, helplessness, terror, loss of control, connection, and meaning. This is at the root of a traumatic experience for individuals. Now, the DSM-5 defines trauma a little more specifically in it that it says an individual must be exposed to death, threatened death, actual or threatened serious injury or sexual violence. Now, this exposure does not have to be direct exposure by the individual. It can include witnessing the event happening somewhere else. A lot of people that witnessed the 9/11 incident developed post-traumatic stress afterwards, considered that a traumatic event for them. Additionally, learning that it's a relative or close friend experienced something traumatic can also be a trauma. This can include the life of one's unborn child, can constitute a trauma. Also, indirect exposure, which is also called vicarious trauma, secondary trauma, our trauma. This is what happens to many of us, sometimes on a daily basis, in the workplace. It has only been, I'd say in the last 14 to 15 years now, that perinatal mental health specialists have included negative events around childbirth as meeting the definition of a traumatic event. That's somewhat recent. PTSD didn't even come on the scene until 1980. But now that we are able to include events around childbirth as being traumatic or meeting this criteria, we now have a way to identify and I guess that's right, identify this collection of symptoms that patients were going home with that previously weren't identified. And these include symptoms in the categories of intrusion, like nightmares and flashbacks, avoidance behaviors, negative cognitions and mood, so not just depressive symptoms, but also self-blame, guilt, anger, and hyperarousal, which included anxiety, hypervigilance, panic, sleep disorders. It's really important for me to state here as well that trauma is in the eyes of the beholder. And what one person might tell you is traumatic might not look the same way from our perspective. And it's very important for us as providers or support people to not triage someone else's emotional experience based on how we think they should feel. And in some discussions yesterday evening, some of the classics came up, like, you should be happy you had a healthy baby. Aren't you grateful they saved your life yesterday? What that does often is it dismisses the chance for that person to express the negative emotions that they are feeling, because they can feel both at the same time. I also want to mention here that traumatic experiences and complications are not the same. One can experience significant complications, those that have ICD-10 codes in the chart, Patient goes to the ICU, major hemorrhage, etc. But they might say, Dr. Vogel, I felt supported. I felt safe. I didn't feel like I was going to die. Yeah, it wasn't fun, but I don't have mental health complications. And the flip is also true, that you don't need physical complications to have a trauma, right? So traumatic events can happen without any physical or identifiable complication. So keep that in mind, because it makes it a little more challenging when we're trying to understand who's had a traumatic event. Another definition of trauma, which I think is really useful, comes from the Substance Abuse Mental Health Services Administration. And it's generalized, but also very specific. And what it says is that individual trauma results from an event or series of events. So if you think about trauma as your big T or little t traumas, it can be a series that is experienced by the individual as negative, harmful, life-threatening, and has lasting effects. And these effects can be not just on their psychological well-being, but also on their physical state, their social state, even their spiritual selves. So let's shift now and let's talk about this concept of what is trauma-informed care. Now that you hopefully have a little base of what trauma is, what is trauma-informed care? Well, this concept and construct has really been around since the 1970s. It came out of the voices from rape crisis centers, as well as those working in the child abuse space, and started to say, hey, we need to do something differently for these groups of individuals. Fast forward, 1980, we had the first definition of PTSD, which primarily came from work with combat veterans. Fast forward, late 80s, we have the VA administration with the first Center for Traumatic Stress, and now we have the Substance Abuse Mental Health Services Administration. Okay? So trauma and trauma awareness has now become more mainstream through a variety of different sectors. So what does it mean to use trauma-informed care? Right? It is a cultural change, as I mentioned. It's not a checkbox activity. It's a shift. And classically what you'll hear is that it's a shift from saying to someone, instead of what is wrong with you, to what has happened to you to bring you to this place, right? So shifting from pointing blame, but understanding that something happened to them to bring them to where they are. Another way to think about it as providers is a shift from us directing care without involvement of the patient. We are going to do this to you today, instead of what can we do together, given where you come from, to achieve a mutually agreeable goal. Right? It's a real shift in how we approach not just patients, but even each other. One that I like to think of is this shift also from seeing a patient as difficult, the difficult patient in room 3, Dr. Vogel, the mean one, the non-compliant one, the problematic one. Right? If we could shift from thinking of them as problematic to symptomatic, would that change how we see them, and would that change how we interact with them, and really get at this perhaps this bias that we have? And an example that I'd like to give is if you were in a patient room and they were using what you considered inappropriate language, they were mean or nasty, put your words to it, and maybe a little combative, but your colleague came in and said, oh, by the way, her glucose is 26. Okay, so you know what to do. You know that symptoms of hypoglycemia look like this. You order the right treatment, and you go home without carrying that burden of, boy, that patient was nasty. Could we do that when we understand what trauma behaviors look like? And we could say, oh, that person is having an acute stress response because they come from a history of trauma. They're being triggered right now. I know what to do because I'm trauma-informed. And I go home that night leaving satisfied and not feeling like I was attacked by a patient. It's different. And then also is this unbiased, non-judgmental approach that acknowledges an individual's cultural context. Now, it does have structure. So trauma-informed care from SAMHSA, Substance Abuse Mental Health Services Administration, gives you 4 R's. We're all used to these R's, right? Realize how widespread and pervasive trauma is throughout our culture in a variety of different ways. And trauma can be interpersonal trauma, which can be things like adverse childhood experiences, child abuse, sexual assault and rape, intimate partner violence, medical-based trauma, birth trauma. It can be community-based traumas, collective traumas from racism, from community violence, bullying, etc. But understand, too, that not only is it pervasive, but there are paths towards healing. Just because someone has experienced trauma does not mean that they can't heal from it and have post-traumatic growth. We need to know what it looks like. What does it look like in us if we've had trauma and we're trying to interact with a patient, but we don't recognize that we're being triggered in this circumstance? Can we give care that's appropriate in those circumstances? We need to recognize it in ourselves. We need to recognize what it looks like in our patients, in their families, etc. Respond, meaning learn about it, learn what causes trauma, and change the practice. One specific example that I'm going to give is that we've learned through the research, through patient narratives, that restraining women for cesarean delivery, especially when they are awake and have autonomy, is harmful, psychologically harmful. And it's usually not indicated in most circumstances from a self-harm perspective. So if we're continuing to do that, we need to make change, a policy change that says we're going to do something that prohibits or prevents this trauma from occurring. And actively seeking to resist re-traumatizing individuals that we know already have trauma, and you can learn to resist traumatizing people in the first place. Now, the CDC has expanded into these 6 principles of trauma-informed care. And you'll hear these throughout some of these other talks as well, because they're core components to other types of constructs. Safety. This is why we're here. It's an amazing conference, and I'm so excited that we're including psychological safety as part of the Anesthesia Patient Safety Foundation. Trustworthiness and transparency. So we have to learn to establish trust, because it is no longer a given for any of us anymore, if it ever was. We have to learn to establish trust, and how do we do that in 5 minutes? Peer support, collaboration, that word's been used a lot already at this conference. Empowerment, how do we give a patient a voice and choice and a sense of control? And then understanding them in their cultural context. This next slide, I rolled it out for the first time last week at a presentation. I've been wanting to do this because I kept reading about all of these things that are circling around out there and how much they all overlap. We're all aiming for the same goal. So I put this up so people could understand. We have the 5th R from the AIM bundles, which is phenomenal. Respectful maternity care. We need that, absolutely. Trauma-informed care incorporates some elements of respectful maternity care, such as the cultural context, safety, empowerment, voice, and choice. Looking at shared decision-making, by definition, it's collaboration. So it fits the collaboration, but also, again, empowerment. Are we listening to the patient? Trust, safety. Patient-centered care, focusing on what does this patient want? What do they value? What do they need from us? Again, collaboration, safety, peer support. Trauma-informed care incorporates all of that, but it also allows for an understanding of trauma. It also allows for the understanding that there can be paths towards healing and resilience, and it also incorporates what's happening to us. Because trauma-informed care is also about our own traumas, so it's important to take that into consideration. Trauma-informed work starts with trauma awareness and builds to perhaps a trauma-responsive, healing-centered system. And I'm going to say systems because systems have to evolve just like individual providers in this space. So what does it mean to be trauma-aware? It means you get a lecture. You learn what is trauma, what are the ACEs, adverse childhood experiences, what are the positive childhood experiences, what does chronic traumatic stress look like in adult survivors, What does an acute stress response look like? So that comes with awareness. What does trauma look like? Okay, then the next step, which I think is the hardest, is getting to a trauma-sensitive state. Can you see something from someone else's perspective? Can you do it? And what does it take to get there? Now it's starting to incorporate some of those 6 pillars into your care, putting that into your plans for delivery. That's trauma sensitive. When you are trauma informed, you're building policies, protocols. All of your practices are becoming trauma informed. You sit and you interact with patients in a different way. And then by the time you get to that healing-centered responsive system, now you're adding this proactive adaptability, which means collect some data. Talk to your patients. Is this working? Are we doing the right thing? How can we improve? And you're using this in every aspect of your system. Everything from your office staff to the people that answer your phones to the clinicians doing the work. And I wanted to mention one newcomer, sort of, on the scene right now, is this concept of trauma-disrupting care. I always thought about trauma-disrupting care as kind of the natural thing we should be doing, which is trauma prevention. But this construct also includes a couple of other, I think, very interesting concepts within it. It hasn't been studied yet, but it's just a construct. But it puts structural oppression at the center of birth trauma. Systematic, structured oppression. It recognizes traumatic situations occurring in real time and basically saying we need to respond to that, learn to recognize it and respond in real time. And I think also what's important here is that it includes reflexive practice for providers. I think that's key. I think this is something that's going to be coming down the road is we need to do some self-reflection on our own traumas. How do we interact with patients? What are our biases? How can we overcome them? How do we identify them in order to get at a lot of the disparities in the healthcare field? A couple slides on why we need this. I think you have heard a lot of that already today, but as I mentioned, there's a lot of pre-existing trauma that can occur, interpersonal, it can be from natural disasters, wars, community-based violence. That can happen before pregnancy. But there are a lot of traumatic events, a lot of complications that occur that have been studied and have been shown to increase the risk for traumatic birth experiences and possibly postpartum mental health issues, including PTSD. So we have fetal neonatal, and I don't think anyone here would be surprised, with a fetal loss or a neonatal loss. That can be traumatic. But so can 1 hour in the NICU. Can be very traumatic. The separation of mother and child can increase the risk. Obstetric-related issues. We've been talking about hemorrhage, sepsis, ICU admissions. But emergencies can be very scary when 30 people run into the room for a code O, or whatever you call it, yours, at your institution. Also, some of the interventions that we use to prevent some physical complications like hemorrhage, when we do manual extractions of clots without the appropriate analgesia, that causes a different type of psychological trauma. And so are we trading one for the other? And then, of course, there's anesthesia-related issues as well. But the overarching factors that contribute to negative and traumatic birth experiences and the increased risk for PTSD, feelings of helplessness and loss of control, minimal support, fear, and negative subjective experience of childbirth. So not only do we have this research telling us what's associated with trauma, we also have patients sharing their narratives. These come from my clinic, just a few. They told me I had a bigger baby and was scheduled for C-section. They separated me from my husband. I remember being strapped down. You're going to feel pressure, they said. I felt everything. I screamed, but they continued. They never brought my husband in. I remember vomiting a lot. I felt like I was gaslighted and no one listened to me. The parts of this story I cannot forgive are the parts that are standard practice. Imagine for a moment being a rape survivor who's been tied down to a bed, naked or nearly naked. That should never happen to any conscious person, not in a calm planned surgery and not in an emergency. The straps were even a greater violation than the catheter. Those straps have haunted me every day of the 2 years since my daughter was born. Those straps broke me. This is a graphic novelette that a patient shared with me about her birth narrative, and I picked out this particular cell because we learn a lot from these patient expressions, patient narratives. Why is this happening to me? Why can't they just get it? What is taking so long? This is torture. I'm in so much pain. I can't handle this. I need this to be over. What is so wrong with my body that they can't place this thing? So what do we learn here? That there's a lot of self-blame that goes into these situations. So we might think they're angry at us, but often they're angry at themselves. So we wouldn't know that unless patients felt safe enough to share these narratives. We also have the retrievals. So patients are going on their own podcasts. This is a big one that just came out in July. If you haven't listened to it, I highly recommend that you do. Again, we're hearing the patient side of things about what is happening, what is traumatic to them. And then we have the consequences. What happens after birth trauma, whether it was re-traumatization or traumatization for the first time in obstetrics? These are just some. Patients can dissociate due to fear or pain, and it could be a coping mechanism that they are used to, and they don't remember the birth. So, as a coping mechanism that once might have been life-saving for them, now causes them to have guilt, sadness, and possibly postpartum depression. Some are angry after traumatic birth experiences. They get hostile. They leave early. They don't come back for postpartum care. They don't come back for antenatal care next time. They write you up on social media. They go on podcasts. They switch providers. They're angry. There's physiological or psychological harm that impairs the ability to breastfeed or bond or have attachment later on. And that can impact the children later on in life. Even the maternal-fetal bond, if there's trauma during pregnancy, we see higher rates of IUGR, hypertension, and preterm delivery. Mental health complications, depression, PTSD, OCD, suicidal ideation, psychosis, anxiety. It's more than just depression. It's a lot. Pain perception. People with mental health disorders often have altered pain thresholds, including those that come from trauma. If we're not careful and we don't pay attention to that, they can have acute severe pain, maybe even develop chronic pain states. The birthday of the child often falls on the anniversary of birth trauma. So that birth trauma lives with them all the time. Unless they get help, this is a very difficult day for them. Some choose to never get pregnant again. Some choose to not come back to the operating room even though they have a T incision. And they say, no, it was too scary. I'll never return to an operating room. I'd rather deliver my child at home than come back. That's how powerful birth trauma can be. And it doesn't only impact the patient. It impacts us, right? These are some interesting data. 18% of obstetricians and residents report significant PTSD symptoms, according to that study. I had a hard time finding studies that looked at anesthesiologists and PTSD. But this is one that I found. Almost 21% had probable PTSD after COVID. Right? So trauma can impact us, and then it leads to job dissatisfaction and burnout. Morbidity is not the only issue that comes after traumatic birth, but we also have mortality. And I'm not going to belabor this point. We've seen this data all morning. Mental health, trauma-related conditions contribute to a significant percentage of maternal mortality. So just to conclude, I wanted to bring up a slide to make us think, or get us thinking about what's our role in all of this. I think for a lot of us in the space, primary prevention is where you can offer the most. And that is, how do we prevent trauma? What can we do to ensure an environment of physical and psychological safety? What can we do to give patients a sense of choice? There are people doing different research projects out there now. Some are looking at including screening questions on their intake for the anesthesia pre-C-section, EPIC board. Some are studying whether or not bringing patients to the operating room before the surgery to desensitize them, familiarize them, give them an immersion experience can decrease anxiety. Some are learning how to sit when they talk to patients and not put their backs to them while they're on the computer, right? And all of these things. And then we're going to hear more about pain during cesarean delivery. What can we do to minimize that trauma and keep patients safe? Secondary prevention is what happens after we think there's a traumatic event. What can we do? Well, one thing we can do is not turn away. We need to make contact with the right referrals. If you have some idea that this person had a difficult experience, tell somebody. Tell the next staff that are coming in, report that to postpartum, so this person gets the support that they need in that time frame. There is some data that using a visual spatial task or even playing Tetris can be beneficial within 6 hours of a traumatic experience for patients. If they play it for 15 minutes within 6 hours, decreases the incidence of side effects, PTSD side effects at the 6-week mark. Perhaps we can study that for providers as well, but trying to implement something like that might be useful. Tertiary prevention. What happens after they've been diagnosed with PTSD? What can we do? Well, we can do lots. There's stellate ganglion blocks happening, and that's an anesthesiology specialty. The team at Stanford is looking at dream sequences or emergence from general anesthesia and looking at dreams and trying to understand what that is doing to allow the processing of traumatic memories. So there might be a role in any of these phases, but there is a role for all of us somewhere on this to help to promote better outcomes. And then just to conclude, this is my favorite slide. What do I ask of all of you? It's curiosity, if nothing else. Can you please think about what's behind the curtain? We meet people in a very short period of time, and it's a very stressful, vulnerable period of time. So if we can open our mind to see what's behind there, I think we can promote better collaboration and get better outcomes. Thank you. I hope I wasn't too far over.
Good afternoon. Thank you for the introduction. I'm very honored to speak with you today on a topic that is both timely and deeply important. So opioid use disorder in pregnancy represents a really vulnerable period for both the mother and the baby, and I think we really have a responsibility to address it openly to improve outcomes. I don't have any disclosures. So today, I'm going to discuss very briefly the prevalence of opioid use disorder in pregnancy and its impact on maternal as well as fetal outcomes. I'm going to review some evidence-based therapies for opioid use disorder and some important treatment considerations. And then finally, I'm going to address some of the stigma in perinatal care and outline some best practices for providing really compassionate, patient-centered treatment. So I'm sure you guys are all aware that opioid use disorder in pregnancy has escalated dramatically in recent years, really paralleling the epidemic observed in the general population. So nationally, when you look at these numbers, the prevalence of opioid use disorder has more than doubled between 2010 and 2017, and really quadrupled if you look even further back from the 90s. And these trends, unfortunately, are a lot worse where I'm from. So the states that are really the most affected are Vermont, Maine, Massachusetts, Rhode Island. Another proxy for the severity of the opioid epidemic among pregnant populations is the incidence of neonatal abstinence syndrome, which has escalated dramatically. So that's in the yellow over here. So neonatal abstinence syndrome is really, if you don't mind going back one slide, sorry about that. It's a drug withdrawal syndrome, generally in about 60 to 80% of babies that are exposed to opioids in utero. So why is this important? So for most anesthesiologists, interactions with this patient population, when they come and ask me questions like, how do we manage this, really focuses on post-operative pain management, which can often be very challenging. But there's a much larger problem to really recognize. It turns out that opioid misuse in pregnancy significantly increases the risk of poor maternal and perinatal outcomes. So much of the data I'm going to present today, I'm thrilled to say, was spearheaded by folks in this room, like Dr. Leffert and Dr. Bateman. Dr. Maida and Dr. Leffert really were instrumental in this work. So this is a large sample size of about 20 million women, and here we're focused on patients with opioid addiction, opioid dependence, and non-dependent opioid use in the blue. So the blue are opioid users, and the red are non-opioid users. And even after adjusting for sociodemographic factors and chronic pre-pregnancy conditions, opioid use disorder was associated with an increased odds of major obstetrical morbidity and mortality, including in-hospital mortality. So if you take a look here, so 2 times higher odds of preterm labor, much higher odds of placental abruption, and women who used opioids. Right here, sorry about that, okay. So women who used opioids during pregnancy were twice as likely to have prolonged hospital stay exceeding 7 days, and were more than 4 times as likely to die during their hospital stay. As you can imagine, opioid use is also associated with worse outcomes in the fetus. So nearly 3 times increased odds of IUGR and increased odds of stillbirth. And you may be asking, at least this was a question I asked, why is this happening? So, more research really needs to be performed as far as direct mechanisms that could lead to this problem, as I think the causes are really multifactorial. So one factor is certainly that women who abuse opioids certainly tend to seek prenatal care late in their pregnancies. Certainly a higher rate of C-section in this population can lead to increased transfusions, challenging pain management, and increased morbidity in general. But another factor that I think is really unrecognized and likely contributing to this problem is opioid withdrawal. And so opioid withdrawal is extremely taxing to maternal and fetal physiology. So repeated episodes of opioid withdrawal, essentially what happens is as a mother experiences withdrawal from medication, from something like fentanyl or previously heroin, there's an increase in catecholamine release that leads to subsequent vasoconstriction, increased uterine contractility, and decreased placental blood flow. And likewise, in the fetus, something similar is happening. So the fetus also experiences withdrawal. So there's an increase in oxygen requirements from hyperactivity. The circulating levels of catecholamines go way up. And essentially, they've actually seen higher levels of catecholamines in the amniotic fluid of women who have acutely withdrawn from medications like methadone. Also, lower gestational age in this population, as well as an increased frequency of preterm birth. So although I probably won't be showing that to my kids, this is not the population to be, removing opioids in this population. And avoiding repeated cycles of withdrawal is an extremely important tenet in the management of these patients. So I think you guys all know that medications for opioid use disorder is really the standard of care. So all women should really be screened, all pregnant women should really be screened for opioid use disorder in pregnancy. And in non-pregnant patients, this is associated with a 50% reduction in mortality. So the medications that we use, methadone has been used since the 70s. Newer drug, not so new anymore, is buprenorphine, multiple different types. So Subutex and Suboxone are essentially in tablet form, in film form. There are some injectables that I've seen a lot of women using, and they've continued throughout pregnancy, so you guys may be seeing those as well. So Sublocade is a monthly injection. Brixadi actually offers a lot more flexible dosing with both weekly and monthly injections. And neither has really been recommended for routine use in pregnancy due to lack of safety studies. However, practically, many women are on these medications. And Brixadi, actually, because you can inject it weekly, I think you're gonna see a lot more of that in the future. Naltrexone is a non-selective long-acting opioid receptor antagonist, which really offers sort of a unique opportunity to remain opioid-free in pregnancy. However, pain management can be tough, and there isn't a lot of long-term safety data in the fetus, although you will be seeing that drug as well once in a while. So there's a lot of risk-benefit analysis as far as keeping these medications on board or deciding to stop that. So which maintenance drug is better to use in pregnancy? So very important to mention a landmark trial in 2010 in the New England Journal of Medicine called the Mother Trial, which essentially compared buprenorphine versus methadone maintenance in pregnant women with opioid use disorder. And for those of us who sort of read and study a lot about these medications, I think we were all surprised at those results. Now, subsequently, Dr. Bateman's group examined similar outcomes with this large cohort study involving pregnant women from 2000 to 2018, and had an adjustment of a lot of confounders that were present in the Mother trial. And this study further reinforced the evidence that buprenorphine is associated with a lower risk of adverse outcomes, neonatal outcomes in methadone use in terms of the incidence of neonatal abstinence syndrome, preterm birth, small size for gestational age. However, there was no difference shown as far as maternal complications or the rate of C-section. So a few just sort of general treatment pearls as far as maintenance therapy. So despite the data I showed you about buprenorphine, if a patient's on methadone, we're gonna continue it throughout. Pregnancy, post-op, all of the rest. Similarly, with buprenorphine, we're gonna continue throughout pregnancy and perioperatively. Oftentimes, these centers that have fancy acute pain services will drop the dose perioperatively in non-pregnant patients, or we'll do things to minimize the agonist effect on the receptor. But in pregnancy, we can easily achieve good pain results even at greater than 16 milligrams because we have all these other regional anesthesia tools. And also, more importantly, discontinuing or reducing the buprenorphine can really lead to an increased risk of relapse. Despite the data I showed you, we're not going to switch from methadone to buprenorphine, again, because it's a partial agonist that, again, introduces a risk of relapse. And one thing to note is that most of these patients will require an increase in their dose in their third trimester. So because the increased clearance and rapid metabolism, it can be really difficult to control withdrawal symptoms for 24 hours on a single dose. So generally, because of the increase in total blood volume, protein binding, increased hormonal levels, we do see that it's necessary essentially to do split dosing. So instead of Q-day methadone dosing, you're going to see BID. Instead of BID dosing for buprenorphine, oftentimes you'll need TID or even QID dosing to just prevent those withdrawal symptoms. So I wanted to switch gears a little bit to another challenge that I faced in treating these patients, and I just wanted to touch upon a little bit about what I like to call a hidden challenge in managing these patients, which is really confronting the stigma and bias. So healthcare discrimination is extremely common and really stems from antiquated and incorrect beliefs that addiction is a moral failing rather than a true diagnosis. And I've witnessed many times that even my own colleagues, these two mainstay evidence-based therapies of methadone and buprenorphine that we recommend, they feel that somehow these medications were simply replacing one opioid or addiction for another in patients that are really lacking the willpower to stop completely. And I've seen a lot of mistreatment of these patients. So I wanted to bring up a couple of studies. So here is one, 100 patients essentially 57 of them reported healthcare discrimination, and this included being shouted at, scolded, threatened, being ignored, told they weren't allowed to have their pain medications. And as you can imagine, with all the other talks that have been given this morning, racial disparities have really only exacerbated this problem. So compared with white women, black women had a substantially lower likelihood of essentially receiving any medication for the treatment of opioid use disorder, and a much lower likelihood of receiving buprenorphine. Pregnant women of color also received about 67% of the dose of methadone at delivery than that of white women. So bias is really pervasive. I wanted to put this slide up because I wanted to sort of bring home the point of how these biases can impact these women. So this is some data out of Massachusetts, population-based retrospective cohort study obtained actually in Massachusetts. And the yellow represents women on pharmacotherapy with methadone or buprenorphine. And the green are women not receiving pharmacotherapy. And so overall, what we're looking at here are fatal and non-fatal overdose rates among women throughout pregnancy. And as you can imagine, the women who are receiving pharmacotherapy was significantly lower compared, as far as overdose rates, compared to those who were not on any sort of pharmacotherapy. So here's intrapartum and postpartum. And interestingly, the highest rate of overdose was at 7 to 12 months, which I found actually sort of surprising. But I think that's an especially vulnerable time for women because there's fewer special services that continue after delivery. So understanding and recognizing stigmatizing behaviors and the drivers of these behaviors, I think, is very important in stopping them. I've thought a little bit about why this is happening, and so I think there's sort of a cycle of how this works, and it sort of perpetuates stigma. So we have all these stigmatizing behaviors, right? So assuming these patients are irresponsible, less deserving of care, there's a lot of stereotyping, so viewing pregnant patients with opioid use disorder as dangerous or untrustworthy, and the us versus them mindset, a lot of dismissing symptoms, so sort of withholding pain medications, and ignoring guidelines, frankly, as far as maintaining these women on therapy. And I think a lot of these stigma are compounded, but what I like to call intersecting stigma. So there's a lot of socioeconomic factors that worsen this stigma. There's some cultural-based intersecting stigma, so media stereotypes about pregnant women, with opioid use disorder being unfit mothers, the belief that I mentioned that opioid use disorder is a moral failing. And then there's a lot of structural and policy-related intersecting stigma. So I'm not sure if any of you have ever been to a methadone clinic, and I've worked in one before, and I have to tell you that, the daily lineups, the urine testing, it all just perpetuates the notion that this is a form of discipline rather than healthcare, right? So, they're not really nice, warm places to be. And I think this just perpetuates the stigma, and they're extremely restrictive. And then there are, of course, a lot of medical and clinical stigma. So many of these patients have have Hep C and HIV as well, which have their own biases associated with them. And then there's a lot of limited provider knowledge about how to even treat these patients. And so I've heard some nurses, some doctors, I've witnessed them say, you really should try to take less of these medicines. And so I think there's a lot of room to expand knowledge in this space. So with those stigmatizing behaviors, you can anticipate what the response is going to be as far as the patient reaction, right? So they don't want to come see us, right, if they're being treated that way. So there's a loss of trust in the healthcare system. There's avoidance. There's increased risk-taking as far as taking medications to manage their withdrawal. And then there's a lot of shame and secrecy about their usage. And the consequences are also quite obvious, right? So missed and fragmented prenatal care, poor, some of the outcomes that I mentioned. And then I think the secrecy, it just ends up perpetuating, right? So I've heard conversations amongst physicians where they say, oh, I went into her medical record and guess what? She actually, she has been using fentanyl this whole time in pregnancy, and she was a liar. And it just perpetuates this notion that these patients are dishonest, and it's just a vicious cycle of stigma. So things that we can do. Language is an extremely powerful tool, and healthcare providers who hold more negative beliefs about opioid use disorder, I think, can really unwittingly isolate and traumatize this population with harsh words. So our words can really convey support and encouragement, but can also create barriers to treatment and recovery. So I've heard all of these words on the left by very well-intentioned people and providers. I think a word that I used to use early when I was treating some of these patients was clean, and I quickly kind of felt like, wow, that doesn't feel like a good word, if the opposite is dirty. Other words up here like habit, abuse, they're just better terms to use that can convey more support. The other things that we can do is to try to see the person behind the pain. And there are a few tools, take it or leave it, a few tools that I feel like have helped me really connect with these patients. The first thing that I've tried to do is to really spend the first few minutes finding just one point of connection. And you may say, like, how is that even possible with some of these patients? But this can take some work, but find a point of connection that's genuine. This can be anything, a hometown that you share, a shared frustration with hospital coffee. This past week, two of the patients, one patient actually, as far as an example, one patient had the same stuffed animal that my son has. And another patient, when I walked into her room, she had an all pink bag of Starburst candies. And I was like, wow, you and I share the same candy. We have the same love of the same candy. So I think that can really just connect you with the patient and humanize the patient. The second thing I do with all of my patients, and this has really been a learning experience, is invite them to tell their story. And I usually say, I'd like to understand your journey. Can you share how fentanyl first became part of your life? You will be shocked at the answer. They want to tell their story. And I found that the most powerful in connecting with these patients. The other thing is to sort of move from measuring to understanding. So really sort of walk in with the mindset that the patient's report is real and worthy of attention without really being quick to judge right off the bat. And finally, I've really changed the way I use the VAS scoring system. I think I've noticed a lot of perseveration and frustration of healthcare workers around this pain score of 0 to 10. I said, oh, Dr. Camder, I walked in and she was sleeping, and then I woke her up and she said her pain's a 15. Or she was on her phone and her pain is 11. Like, how is that possible? So rather than thinking of the pain score in that way, I sort of made my own pain score up. And and I think this is good for the trainees as well. So for me, a 10 is I can't talk and I can't breathe and I can't move. A 5 is I can do everything I need to do, but not the things I want to do. And a 0 is I can do everything I want to do. So I asked the patient, can you walk me through what you can and can't do? So more of a functional pain score, essentially, rather than, tell me what your pain score is. Finally, and this one I think is extremely important, give options. So do you want to drop the ketamine infusion today, or do you want to drop your IV Dilaudid? Empower these patients to help make some of the decisions as far as pain management. So caring for pregnant patients with opioid use disorder has really been one of the most meaningful parts of my work, but also one of the most humbling. And so, you know, it's been a challenge for me to recognize and intentionally dismantle, I would say, my own biases. And I want to be honest with that and be brave. So I'm going to share a story about my own journey. And this is a true story, and I've received patient permission to share it. So I'm just going to read this. So when I was a CA2 anesthesia resident, I was asked to remove an epidural for a young woman who had just undergone a cesarean section. The patient was 20 years old and had a history of opioid use disorder with heroin. I remember going to her room for this seemingly simple task, but when I entered, she was crying and in too much pain to sit forward for me to access her lower back and remove her epidural. I went to my OB anesthesia attending for guidance, and he followed me back into the room. He suggested that it might be easier with an abdominal incision to lie her completely flat and roll her to one side, which seemed very reasonable, but she adamantly refused to lie flat on her back. The more we pressed, the angrier she got, and the more distressed she became. Eventually, with IV Dilaudid and a large epidural bolus, we helped her lean forward. As I focused on her spine prior to pulling the epidural, I noticed a dark, moody tattoo etched across her shoulder, which said, "For every dark night, there's a brighter day ahead." I didn't think much of it at the time. We removed the epidural and stepped out of the room. The nurse followed us out and muttered in frustration, "Wow, that drug addict is a nut job. She should consider getting a tubal so she doesn't bring another addicted baby into this world." My attending added, "That's an understatement." I felt really uncomfortable by these words, but nodded my head in agreement. Fast forward to nearly 2 decades later, and I was attending on the acute pain service where we were consulted for a 38-year-old woman with opioid use disorder recovering from an open heart surgery for infective endocarditis. The cardiothoracic surgeon fellow called me and warned me, "Brenda, this patient is totally crazy. All my resident tried to do was remove one of her chest tubes, and she started cursing at us and totally flipped out." Later that afternoon, I met the patient with the entire pain team. The patient was disheveled, missing both legs and most of her teeth. Tearfully, she explained that earlier that morning, while she was half asleep, a surgical resident came in, put the head of her bed down, raised her arm, and yanked out the chest tube without warning. She felt violated. I apologized on behalf of the team and assured her we'd approach the remaining drains and tubes differently. We discussed many sedation options, Dilaudid, ketamine, Valium. She was open to anything, as long as we didn't put the head of her bed down and lie her flat again like that. Then I asked a question I already suspected the answer to. "Why can't you lie flat, my friend?" She lowered her gaze. "From the time I was 12 until I was 14, my stepdad assaulted me at night. I've slept upright in a chair with my arms crossed over my chest ever since I ran away from home, so I can be ready, so I can protect myself." The room was silent. We listened as she told us how, after running away from home, she spent a year of high school sleeping on a friend's couch until she was no longer welcome, how she then lived on the streets, and how at just 16 years of age she began using IV heroin. We made a plan for the remaining chest tubes removal, sedation with our team at the bedside, seated position, full control in her hands. As we prepared to leave, she stopped me. "Dr. Kamdar, before you go, can you help me adjust my pillow?" As she leaned forward, her gown shifted, and I couldn't help but notice a tattoo on her shoulder. "For every dark night, there's a brighter day ahead." It was the same patient. Thank you, guys.
Thank you to the previous speakers, and for that anecdote, I really don't know how to follow it. I sat there thinking about it and I totally forgot it was my turn. So thank you for that. And also grateful to the APSF Planning Committee and to May for making the time today to talk about these important topics. I think it really is part and parcel to what we know APSF to be all about in terms of revolutionizing and really pushing the boundaries of patient safety. So it's an honor to be here and to spend time thinking about these questions with you. My name is Grace Lim, and I am going to be talking about patient-centered care, quality, and setting up a research agenda to address issues. But May also instructed me that I was supposed to talk in a way that will engender conversation, which I'm excited about, and I certainly have really enjoyed about this meeting format so far. So I'm going to spend part of the time telling you a bit about this thing called the Elevate Project, where we attempted to tackle some of these questions. But I'm also hopefully going to spend some time posing some questions back to you. And I'm really hoping that by the end of this conference, we will come away with not only a shared agenda here, but maybe some tractable things we can really do to, once again, push the envelope and push the agenda further and to really make some reform here. So I do have some disclosures. The relevant ones to this talk are that the work that I'll be presenting to you was funded by PCORI, and that I'm working together with a large language model innovation company at CMU that's going to be developing some communication tools to be used at the bedside along the lines of the things that we're talking about today. We are here because maternal mortality and morbidity in the US remain unacceptably high. I'm hoping we're at a point in the conference where none of us will argue this point, and I'm not going to be sharing any more data about this because I think you've all seen as much of the data that I know about. But I also am hoping that at this point in the conference, we are coming to a shared realization that maternal safety is not only about physical survival, but it's also about dignity, respect, autonomy, mental health, and long-term outcomes. This is the next frontier, I think, of anesthesia practice and how we define patient safety, and I'm so glad to be thinking about these things together with you today. For a long time, for several years now, we have recognized that women deserve more than just to know they're going to survive childbirth. Since 2018, the WHO has made statements, has made recommendations really focused on elevating the need for delivering respectful maternity care. And so these are not new issues, although these might be new ways that we are framing them and hopefully disseminating them. And so as anesthesia professionals, I think we really are this bridge between recognizing the need for physical safety, not only for mother and child, which we've talked a lot about today, but also the mental safety that's required of achieving those really good outcomes that I think we are all striving for. And so far in this panel, this segment, we've talked about trauma-informed care, substance use disorder, and management. And I think that is part of a systemic solution in terms of that's how we show up at the bedside. And so if that is how we show up at the bedside, then patient-centered care and developing research and pursuing those agenda are how we show up at the system level. And so I do think that these are both equally important and deserve equal amounts of attention, effort, and ATP. So here we are I'm supposed to talk to you about this, and what I'm gonna do to try to accomplish this goal is to tell you how we attempted to tackle these things in terms of quality research agenda through the Elevate Project, which stands for Advancing Patient-Centered Care Anesthesia Choices During Cesarean Delivery. This was a labor of love between several professional organizations and experts. We were lucky to bring together not only anesthesia professionals, but also payers, quality experts. We had representation from our state maternal quality collaboratives, but also had representation from those in insurance payers and those who are informing Joint Commission and CMS in terms of how we report and measure quality bundles. So the reason why we got all these people together is because, once again, we work in a system of care. So it not only is about how do we show up at the bedside and what do we do for that patient in front of us, which is extremely very important, but how do you systematize that across every single patient that has the same condition, whether or not it is you at the bedside or your colleague that you have been working with to improve these pieces of care. And so we got this group together to give voice to the issue, and also to put together an agenda that was comprehensive and took a multifactorial, a multifaceted lens on just how to systematize these potential solutions. And so the problem we were trying to tackle was pain during cesarean delivery. We also learned by opening up this can of worms, there was a lot of other things that go along with that. Quality of labor analgesia management, quality of conversations, prenatal anesthesia consultation. And the obstetricians who were part of our group also raised the fact that we are probably, as a system, not great about talking about cesarean deliveries in general. So patients are showing up for care needing this thing at the 11th hour, spending most of their 40-week gestational period trying to avoid this thing that we are now confronting to have to deliver to them within 5 minutes. But that was the thing that brought us together, was what we were all, trying to solve a problem regarding pain during cesarean delivery. We also recognize this lack of ability to engage true shared decision-making during these situations, that the lack of trust in some of our demographics is also factorial in these issues. And then we also recognize that pain is only one outcome, and potentially for a long time we've really been focusing on this number, but patients have a different perspective on what's important. And although although this number may be important and is measurable, replicable, scalable for us, they also prioritize other things like how they were spoken to or whether they felt they were listened to, which are not as easily measurable in those situations. So our focus was to try to empower patients through informed anesthesia choices for cesarean deliveries, and we were attempting to bridge these critical gaps in experience, safety, and equitable care access. So these were our goals. We also had a vision where, a world where all birthing people are able to receive equitable and personalized and evidence-based care. Some of you are in this picture, and I'm thankful for all of your participation. You might notice, and May, thank you very much as well for being part of this group. Our methodology was primarily a mixed method, meaning this group convened several months before a summit that we held in person, and had several conversations with us, not only one-on-one interviews, but also completed sort of targeted surveys. We used both of these things together and in a cycle, so that the interviews informed the questions then informed the data, informed additional interviews. Essentially, we were iterating on what the key issues were, what the barriers were, what the facilitators were for a potential solution, and whether we could even arrive at a consensus on what an agenda should be. And so we learned a lot in these conversations, and thematically found that we had shared ideas about the fact that this was an issue, but also had disparate ideas about what patients thought were solutions versus what payers thought were important and what quality experts thought were tractable. And so through the in-person summit that we had in January of this year, those were really the key issues, the unresolved issues that we were not able to get through this initial mixed methods approach. The reason for us getting together was to see if we were able to resolve some of those items. And all of these things can be found at elevateproject.org. At the bottom, you can abstract the report that has everything that we did together on there, the results. And so I mentioned some of the stakeholder engagement here. We had diverse sampling here across multiple stakeholders, at least 40 organizations, trying to get a representative sample not only of academic organizations, but also community practices, both urban centers and also rural centers. And I mentioned that we were interested in including community perspectives as well. So we had patient advocates and doulas as part of our teams as well. And so these are the highlights. We identified core research priorities related to this topic. And the power of this is that this was not only the OB anesthesia experts deciding that we were going to compare cocktail A versus cocktail B. This was OB anesthesia experts together with all these other stakeholders saying, okay, that sure is interesting, but maybe we should be thinking more broadly in terms of how the care is also delivered and measuring outcomes that are more distal or long-term, which is what's important to patients, and then measurable outcomes on mental health, which is has been lacking in some of our pain research so far. For patient-centered outcomes, we arrived at several understandings. One is that certainly pain management is important. Patients did say that, but also they truly value a sense of control, autonomy, and feeling heard. They want to have limited long-term trauma. They're clearly trying to balance this with neonatal success goals. They also think that the HCAHPS things that we do here with patient satisfaction is not necessarily helpful in these ends, and that was an interesting nugget of information that we learned. And just sort of trying to navigate these conversations while balancing their different priorities is something that they found valuable also. A key finding we found here, and we've, in some subsequent research that our group has done, we've replicated these findings at least a couple of times now, is that patients and stakeholders aren't patients and providers, are not necessarily on the same page about these goals. Now, that might be initially surprising at face value, but when you think about it, it may not be as surprising. When you're confronted with a cesarean delivery, which many of us might find as routine, we do many of them every day. Maybe in our career, we've done several thousands of them already. We have certain high item things on our agenda that need to be done. Oxygen, if necessary, for the baby, timely administration of the anesthetic, several other things. However, for the patient, that is their first experience with it. They may not have the same goals in terms of receiving medication for what might be perceived as discomfort if they had not been, talked to about that at one point. So what we learned in terms of our mixed methods analyses over here is that there are quantifiable ways in which patients and providers are actually prioritizing very different things in that moment of care. And that should be seen not necessarily as a major problem for us, but it should be seen as an opportunity for us to partner better with the patient, recognizing that, okay, in my mind, as a provider for this patient who has to do safe and timely care, I know I need to do X, Y, and Z, but how can I also meet their needs where they kind of just need somebody sitting there talking to them and telling them about everything that's going on? Meaning I don't have to be the hero in this conversation or in this equation all the time. Perhaps the labor and delivery nurse could be helpful right at the bedside, right next to me while I'm applying monitors and talking to the patient, especially since they have a rapport with the patient that may be deeper than the one that I just formed with them. Or similarly, and we'll talk about this in a little bit, but the role of doulas. Doulas are non-medical but patient advocate types of people who stay at the bedside with patients who are in labor. Many of you who do labor and delivery encounter them all the time. There have been many conversations that we learned through Elevate about the potential role of doulas in these situations. They're not typically thought of as OR team members or even as care team members, but is there an opportunity for us to get creative about the people in the circle of trust with the patient so that we can all move to the same goal of a good outcome from a mental health perspective? And then we also discovered barriers. There's some systemic barriers. We heard a lot about how, wouldn't it be great if we could all do prenatal anesthesia consultations? Immediately, some barriers that we heard about were in the private practice where, you have one anesthesia person doing all the things, and there just is not a feasible way to get on the phone with every single pregnant person who may be coming that day. And so we may have an opportunity here to get creative about the way we do prenatal anticipatory care. Once again, do we have to be the heroes of this equation? Do we need to bill for that? Or is there a different way that we can integrate this type of education as a team with the patient in a way that meets their needs while also confronting the realities of the strained workforce that we all have on the anesthesia side of things? And we also talked a lot about facilitators, in terms of things that we can leverage now or in the future to address some of these considerations. We definitely heard a lot about the need for building trust and building these relationships. So that increased presence of support people was something we talked a lot about. We discussed risk assessment tools. Are there better ways that we can help the providers at the bedside to recognize a situation that needs intervening? evidence-based driven medications for shared decision-making, and then care that supports patient autonomy and controls are other things that we found as facilitators. So these were our key findings. All of the stakeholders together can agree that the patient-centered things that are important for patient-centered outcomes that are important include a sense of control, managed pain, emotional and mental or psychological well-being, and neonatal success. We also identified barriers, facilitators, and multi-pronged solutions. And so when I was thinking about this in the context of this meeting, I got very excited because APSF has this rich history of transformative care that radically improved anesthesia, so that and you're all familiar with statistics. IOM has held us up as a poster child for patient safety. We went from the #1 killer of people having surgery to the least likely thing. And how did we do that? A number of ways, one of which included better tools, better monitoring, the pulse ox. I just had a great conversation at lunch with Alex and Tim, who told me about their experiences throughout their professional life of going from not having any of this, looking for BRB, bright red blood in the field as an indicator of oxygenation, to a revolutionary practice of adding this very simple thing to the patient's hand and identifying oxygenation before you could see it. Unfortunately or fortunately, this device is now in the Wood Library Museum. And there are some people in the audience who remember even using this Nellcore device. But it really got me thinking about what is our pulse ox to this solution? This past hour here or so, we've been talking a lot about some pretty abstract things that are not measurable by a pulse ox. And yet, in order to make that needle really move, perhaps we need something as simple and scalable as a pulse ox to tell us when something's going on and to give us some directionable action. And so I think that's a key question that I'm going to pose to you, and I'm going to be really eager to hear your thoughts about it in terms of what are our scalable solutions. I also think about it in the context of this major challenge here we have, this issue of scalable solutions. This challenge of, how do we get a best practice out? And I was glad to hear about some of the implementation science ideas that are, through the experts that we heard this morning. But here's the reality. There are more than 5,000 hospitals in the US, of which, 2,300 or so are doing deliveries. And that number is shrinking, as I'm sure some of you know. And so those are the numbers, and yet these are the numbers of, let's say, accredited USA medical schools, which is, there's only 120, so that's kind of the way I tried to get an idea of how, university-affiliated training institutions. I'm sure there's a better way to assess this, but they're a fraction of those hospitals, in other words, that are in the environments that many of you and I, we are coming from, a teaching environment that has the ability to influence what the next generation does with these challenging situations, for example. And, similarly, a fraction of those that are accredited anesthesiology residencies. I was not able to find similar numbers for the SRNA programs, but I'm sure some of you are familiar with these numbers, and I would wager to guess that they're in the similar hundreds or so. So a fraction of the number of hospitals and training programs, in other words, are representing the opportunity for influencing training and education on what happens in the 5,000 hospitals that, or specifically 2,300 of the maternity hospitals that are delivering maternity care. So that's a pretty big gap, I think. And quantifying it in those terms, I think, is also hopefully helpful to this audience in terms of thinking about that scalability question. What is the bridge? How do we bridge this gap between the training and what's happening everywhere, which is a pretty big gap? So we heard some of those ideas with Dr. Main earlier in terms of using some of the hammers and levers that we have with accrediting organizations. Is that a direction we need to go? What's our pulse ox here, basically, or the next generation of a pulse ox? And so I'm going to take a page out of our anesthesiology history books and think about this together with you. How did anesthesia become safer? What does the IOM, the Institute of Medicine, say when they were, holding us up as poster children? They brought up, consistently we hear about three things. One, increased and improved safety standards. That really comes down to training and education. 2 was advanced monitoring, EKG, the pulse ox, capnography. These are what I'm going to bucket as tools, because although I can't immediately imagine something in those categories that might help us with these situations, although perhaps it's just a lack of imagination on my part, that just kind of buckets into this idea of tools. And then finally, improved drugs and delivery systems. So moving from very impractical or the drop methods of highly dangerous volatile agents to better and more targeted therapeutics that going through the intravenous route. These were really important innovations and new approaches that revolutionized the way anesthesia care was delivered, and all of these things together made anesthesia safer. And so once again, I'm going to pose to you, what are these implementable, scalable solutions? How do we implement them? How do we test them? What are they? And so for example, when it comes to training and education, do we need to revise, revisit, re-examine our boarding process, the milestones, for example? How do we assess these types of competencies? How do we teach them? Is there a standardized curricula that needs to be delivered at each of those 180 institutions or sites? The current workforce would need to be brought up to speed as well. So these are things to think about. One way that we approach this is through the delivery or the teaching of empathy skills with a mnemonic called NURSE, which stands for name, understand, respect, support, and explore. We have a little letter in anesthesiology that was published not too long ago showing that this did make a big difference in not only the patient's feelings or the measurable instances of trauma or acute stress disorder, but also the residents felt more confident in their ability to deliver empathetic care in high-stakes situations. So perhaps this is one of potentially many solutions of scalable, curricular ways that we can teach this, not only to our current, next generation, but also to people who are currently delivering this type of care. This pulse ox idea, do we have standard monitoring schemes? I don't want to steer, break any surprises here, but I'm hoping we'll hear from Dr. Heather Nixon a little bit later today, who will talk a little bit about some innovations that she's done in terms of assessing intraoperatively, how patients are doing in ways that are actionable. Or are there some innovative devices that can help us, raise awareness on what is happening here and what we can act upon? And then finally, once again, in the past, we moved from halothane and other types of volatile agents to more targeted intravenous approaches or better inhaled anesthetics as well. Do we need to think about some new approaches to the way that we deliver care? Are there new or different pharmacologic approaches? Do we have to should we reconceptualize the role of support people, not only at the bedside in the labor suite, but also maybe in the operating room? These may not be immediately obvious questions that can be answered right now at this moment, but perhaps are questions that are worth contending with or wrestling with. And so, taken together, I think that if we take a page from our history books and think together about what we might be able to do that pushes the envelope, that really does tackle these problems in a meaningful way, then perhaps we can move the needle on some of these issues that we've been talking about. And so that's all I have for you. Thank you for your attention and your time. And once again, these are just some ways that you can get to the report and other key findings from our group. So thank you.
Afternoon, everybody. I know it's been a long day and lunch is setting in, so if you will, just we're going to get into our feelings. And so a couple individuals will be walking around giving you guys some little therapeutic cards. My name is Miranda Klassen. So sorry, I'm just getting oriented up here. So again, my name is Miranda Klassen. I am very privileged to be here with you. I experienced an AFE during the birth of my son in 2008. And to orient you back to 2008, there was no TikTok, there was no Instagram. we were still asking Jeeves for advice, typically like, what good restaurants? And like my newborn kiddo, Google was in its infancy as well. So I just want to reorient us back to that time. And so in the moment that my son was born, I didn't realize that so too was going to be a new passion and a new path forward for my career. 4 months after this picture was taken, which was taken 2 days after he was born, he was asleep in the NICU. They brought him out to me. You can tell that I was still hooked up to a lot of lines. And I really didn't have a lot of understanding of what had happened to me, let alone even sort of realizing that I was a mother. And he was asleep, and I sort of grovelly said, "Hey, Bubba," and he immediately woke and started to cry. He's been pretty. He still likes to cry, or make me cry because he's 17 now. But what I realized too was that instant, like, I became a mother. But 4 very quick months after that, I faced my 32nd birthday. And for me, my birthday is a difficult time. It's not one that I really enjoy celebrating anymore. Really, his birthday is like the big day in our family. But I knew that I didn't want anything material, but I really needed some time alone, and I really wanted to better understand what had happened. And guess what? Jeeves did not know anything about amniotic fluid embolism. So I had to go to the library, a place that I had found a lot of solace during college. And so I went back to the library and started to look and started to read. And as I read, I realized that the articles were very complex. I didn't understand half or more than half of what I was reading. Again, remember, Google wasn't around, nor was ChatGPT, so I really had to figure out what DIC was. And as I read, one of the things that what I did understand was that it underscored exactly what the providers had told me when I woke up or when I was extubated, that this was extremely fatal and most women passed away. At the time, AFE was roughly 80% fatal. Again, this was before a lot of ECMO usage. This was before hospitalists. This was before TXA and bundles. And so the fatality rate was incredibly high for mom and for baby. And while I was there in the library, as fate would be, blogs were a big thing back then. And I came across a blog, and this blog caught me by surprise. It also caught the librarian by surprise because she was actually sitting with me as I was trying to look for articles. And essentially, it was a sister talking about the loss of her sister and her nephew, Jenny and Broden. They had passed away. When I saw the date, I gasped. It was April 1st of 2008. My AFE was April 9th, 2008. She too was blonde and blue and was having a little boy. And so the seed of survivor guilt that started at extubation started to flourish in the library. And I thought, what a cruel, cruel day of April Fools, because this was certainly no joke that mothers and babies were dying in the 21st century in the United States. And so I knew I needed to do something. And so there in the library, I had formed in my mind an organization that would support research and it would support families who had gone through it. As I read the articles, I found a common name that was on all the articles. He was either quoted or it was an article by him, Stephen Clark. And God bless these printed articles because you first authors know this, your email or your phone number is on there. Now again, 2008, remember, we protected our emails. This was like your social security number. So to have an email address of somebody was pretty exciting. So I decided I would send Dr. Clark an email that I just had an AFE, or so they thought, and I was going to start this organization, and I didn't want to do it without expertise. He was the foremost expert in Swan scan catheters. He was the foremost expert in AFE and really founded critical care obstetrics. And so I had a trip to the library, and then a month later, with a massive pulmonary embolism in my IVC filter that I did not know about, hopped on a flight to Utah. If you're not from Utah, there's definitely elevation there. I did not feel well, but I was not going to miss this meeting. So I met with Dr. Clark, that was 17 years ago. He professed his support along with his colleagues, and he is still a mentor, a friend, and very involved in our organization and our research. But enough about my story, because why I'm here is really talking about centering the patient, and I have some patient stories and some provider stories to share with you. This is a special one. Told myself I wasn't gonna cry. This is Teresa, and this is her husband, Dave, and this is Dave kissing Teresa, welcoming like the new year. And it's one of my favorite pictures of them just because it encaptures a lot of their personalities. I didn't get to know Teresa. Unfortunately, Teresa passed away, but I did get to know Dave very well. He was actually the first family that came to us 6 months after I started the foundation. In fact, this weekend, I'll actually be cheering Teresa's sister on. She's gonna run a marathon like her sister did, and so I'll be cheering her sister on, Anne. But I've become very close with their family over the last 17 years. Everything from her parents, her best friends, her dog, you name it. I was somehow welcomed into this family and into this space because I was so passionate about ending it and making sure that women like her weren't lost. But I'm actually not here to talk about Teresa. I could literally spend our entire conference talking about her. But I want to talk about her anesthesiologist. Dr. G was the attending the night that Teresa earned her angel wings. He had just turned 40. He was in a small town, and I remember telling Dave on my many calls to work, the way I would talk to Dave every day, and I told him how important it was that he needed to, take care of himself, and so he was going to the gym, and he happened to see, I remember the day he called and he said, I saw Teresa's anesthesiologist at the gym. And I was like, well, did you guys talk? And he goes, no, we kind of like had an unspoken bro code. Like, we knew who each other were, but we weren't gonna talk. And he saw him a couple of times over the next year. What we didn't realize was a year later, a year and 2 weeks later, Dr. G would earn his angel wings too and took his life. And I have no idea what events transpired that led to that outcome, but I did find something that was quite interesting, and I want to bring this to your attention. Is on his obituary page, there are countless tributes to him and what a special person he was, but one of the tributes was incredibly telling. It was a nurse who had been in the same room with him and Teresa that night, and what she essentially was saying was, we understand that your pain was heavy. We understand that you didn't want to come to our unit ever again. And we missed you then, and now we're gonna miss you going forward. So today, I wanna talk about how our organization has learned that we have to not only support patients and their families, but we have to support all of you too. And so our job is to try and keep you, one, at the bedside, but to be ready for these events. So in short, this is sort of what we do. We are grateful for people like you, for May, for Elliott, for Vibha, for Paloma, for Barbara, for David, for all of our colleagues and many that I just named as anesthesiologists that trust us and are willing to lean into us and collaborate with us and give us the validation that we need and the input that we need to not only do our research, but to do all of the other things that create resources for you. So we essentially help provide you or prepare you for the event. We help support you during the event, and we are definitely there in the aftermath of the event. So I want to talk mostly about, what inspired me that day was the research. My background was biology and chemistry. I thought I was going to study bugs. Now I'm studying moms. I'm actually studying, I think, what might be the hardest thing in the world to study, because we know virtually nothing about it in the last 100 years. But what we decided was to revamp Dr. Clark's registry that ceased in the 80s and reinitiate that registry. And then we also came to realize that retrospective data could only get us so far, that it really comes down to getting specimens. We really need to study what is happening, what biomarkers are involved, the proteomics, the metabolomics, you name it, we want to know what is going on. And there's no way that we can do that without specimens. Our registry is the largest database in the world of cases. I've been privileged to serve on the MMRC in California. Thank you, Dr. Main. And so I've read all the cases from our registry and many cases as well. And again, I can just underscore that what we really need is specimens. But we can't do better for patients if we don't get these specimens, and we can't get specimens if you don't know how to give us specimens. So that's why opportunities like this and collaborating with patient organizations is so valuable. In addition to our research, we offer a number of resources. This is a very busy slide, but what I want to draw your attention to first is on the bottom left is our simulation toolkit. I know some of you have mentioned SIM. I believe there's going to be a SIM presentation later in the afternoon. Wow. Tell you what, talk about triggers. Being, I think straight out of the gate, I think the next year, my husband, which I probably should have shared, is an ICU nurse. He became an ICU nurse after our experience. We thought it would be a good idea to present at a hospitalist conference, and they decided they wanted to run our sim, or run our case, and so I played the voice of the patient, my husband played the voice of the husband, and we did a simulation of our case. And it was fascinating to me to watch simulation sort of unfold. So I've had like this very deep respect and admiration for the process of sim. I've learned a lot over the last 17 years. But the SIM toolkit was many, many years in the making. It was a collaboration with Clinical Concepts in Obstetrics and Julie Arafay, who is a simulation expert and human factors expert at Stanford. So we developed this turnkey toolkit for essentially low fidelity to high fidelity. It has everything that you need in this kit, and it was really designed to assist units in running AFE SIMs. And some of the information we got, we just actually presented at A1, and it was really fascinating to see. We had almost 600 people in the room. They had to turn people away. It was standing room only, and it was because these nurses were very hungry for the information. And what we asked when we were talking about, so this presentation was on the implementation of simulation, and what we asked was, do you ask your anesthesia colleagues what do they need to be successful when they come rushing into the room? What do nurses need to be successful, but what does the ad hoc team need to be successful? And so we asked a series of questions. What you need to ask your anesthesiologist or your CRNA, what do you need to be successful in every labor room if this happens? So afterwards, we opened it up for questions, and some of the questions that we heard was, how do we get our colleagues, our clinician colleagues to the table? And what I heard them say was, we need our colleagues, we need anesthesia to come to these things, because when they come to our SIMs, we communicate and we figure things out. We realize that, oh my gosh, somebody doesn't have a key to labor and delivery. A little side note, I told my husband after learning that fact, he leads the code team at our hospital where I was, and I said, hey, just see if you can get in to labor and delivery. He's like, oh yeah, I can get in anywhere. I was like, okay, we'll try. Well, he couldn't. It was an IT risk management issue. So it's really interesting the things that come up with simulation, and it was really interesting to hear the dynamic of nurses talking about how profoundly and desperately they wanted anesthesia colleagues to be there. I'm so sorry, can you scroll just a little bit down for me? I don't know how I can, thank you, maybe that's me, you, I'm not sure who's doing this. In addition to our SIM toolkit, we also have a number of other resources. We have a checklist that helps labor and delivery nurses prepare not only the patient, but prepare the room so that when you guys come rushing in, you have space at the head wall, you have the ambu bag set up, you have the tools that you need necessary to intubate this patient. We have fact sheets, we have patient lay-friendly crisis handouts, we have a course. We have tried to make every barrier be removed, because the barrier of AFE is that it's infrequent, but it's very fatal. But you guys have a lot of cognitive load. You guys have to know a lot of things about a lot of things, and thank goodness I only have to know one thing, which is AFE. It just happens to be very challenging. We've created badge buddies to assist nurses as well. But we also have a hotline, and this has been modeled after the malignant hypothermia hotline. How many of you are familiar with MHouse's hotline? Okay. How many of you were aware that AFE had a hotline? oh my goodness, you get a prize. You get a prize afterwards. Might just end up being a hug, but you're definitely gonna get a prize. And so that's why I'm here. I wanna share this hotline with you. So while I'm not a provider, our hotline does exist, and we are looking for a little begging. We are looking for providers to assist us. But this hotline allows for you to call either during an event or after an event so we can walk you through next steps, because as I've come to learn, a lot of people don't know what to do when these events happen. That is where this little card that maybe you have on your table or maybe you don't, I could only bring so many because those pesky airline poundage. But essentially when a loss occurs, your autonomic nervous system, especially for nursing colleagues who are not as stress inoculated as maybe some of you, are having a pretty significant response. Dr. Vogel, I think you were hitting on some of this as well. But what we try and do is and normalize a very, very, very abnormal situation and step in to assist, recognizing we've been there, we understand where risk management's coming from, we understand where different providers may have different feelings, and no case is ever the same. We start to learn about the family dynamics. We start to learn about the unit. Does the unit have a lot of support? Do you not need a lot of support? When you call our hotline, you activate essentially all of our resources. We send food. We send food at 2 in the morning. Thank goodness for DoorDash. We work on how to prepare your conversation with the medical examiner. I've done an extensive amount of work in maternal autopsy, which is a discussion for another day or tonight if you're up for that. But we advocate for autopsy. We discuss the importance of it. We help the family preserve immediate memories because, unfortunately, this patient may pass away and may need to go to the morgue. And so we are working with the families immediately on what they need to do. And all of this support that we've done has also been under the guise of expert perinatal trauma experts in our community that have either lived this experience themselves or been touched by it. We do a number of things for our families. You could probably tell how emotional I was with Teresa. Every story is important. Everyone is meaningful. I have a wall of their pictures a wall of their black and white photos in my office, because I do this work for those that we lose, but we also do this work for my sisters, if you will, those who've survived these events. And there's a lot of platitudes. I think someone also shared this, maybe it was probably Dr. Vogel, that shared the platitudes of well, you're just so grateful to be alive and it's a miracle and things like that. And so we have to really help these patients unpack that you can be grateful to be alive, but you can also be really sad and really angry and really frustrated or confused or traumatized. So we've created a number of resources. We have a very comprehensive survivor guide. And you may be thinking out here, but we don't necessarily get to see this patient. And I'm going to share some other stories. But this survivor guide is comprehensive. It's interactive. It can be airdropped to the patient's family, to the patient themselves. It can be downloaded. We will send them a hard copy as well. We also created a survivor clinical summary form because guess what? You guys have done a good job keeping us sedated, and we have no idea what's happened to our bodies. And so that autonomy and not understanding what's happened, we've created a form that can be completed by the clinical team, all of you that are supporting this patient, to sort of summarize what happened to our bodies and the key findings and the key interventions, so that when we go out and we go to the next doctor's office visit, which we have a lot of ologists we have to see after these events, contrary to what many people think, that the event is over, it is not. Many of us have long-term physical and mental health sequelae. And so we've created this two-sided form to assist in the continuity of care for these complex patients. But we really have created a warm sisterhood, and we support not only survivors, we support grieving families, widowers, spouses, siblings, best friends, you name it, we have a group for it. But I want to share a story, which is an interesting story, and again, it involves an anesthesiologist or CRNA, about resilience and about community and about education and why our organization has been able to support more than 200 women, AFE survivors, go on and have a subsequent delivery And fortunately, knock on wood, none of them have had a subsequent event. On the left, in this whole picture, Olivia to the left. Let me just tell you briefly about Olivia and John, her husband, both in the military, both lieutenant commander for John. He's an MH-60 pilot. She's an ED trauma nurse. They've been deployed. They've seen their fair share of not so good stuff. Let me also tell you, she's a wicked redhead from Brooklyn who played college hockey. So she is very, very tough mentally, physically, and she's become a dear friend. But in this left is shortly after she was taken off of ECMO and getting to see her son for the first time. But what happened during her AFE was a little unusual, but also bears to be repeated, is that she did not immediately lose consciousness. And so during her AFE, as she was becoming hypoxic and hypotensive, there was a flurry of stuff. Now, mind you, she's an ED trauma nurse, so she knows what's going on. Unlike people like me who are like, am I gonna die? That's what we say. She's out here calling the shots, and she calls herself like an old sweary broad. She will tell you that she was literally calling her own code, like halfway through it, telling people what they needed to do. So her sweet CRNA, Kim, happened to be there, and Kim was not only caring for Olivia, who had probably some sweary words, she also was trying to manage the code, and then additional colleagues come in with different military ranks, and there was a heated discussion about intubation and when intubation should be done. Long story short, Olivia was intubated. She developed ARDS and did go on to require ECMO. She was transferred to another facility off base, and there at the next facility, she was sedated, but what was unknown at the time was that, remember, she's a redhead, she is a hyper, what do you guys call it? Metabolizer. Thanks, see, I read your lips. Can you tell I'm not a provider? So she's a hypermetabolizer, so she ends up not actually being sedated, but she's paralyzed. So what does she see? Ceiling tiles. These look nothing like what she was looking at, the old kind with like drips and stains, right? She also hears, how many of you know anything from MTV, Ridiculousness? That's a little pop culture reference, I'm sorry. Anyways, it's a silly show, and there is someone on there who has a horrible laugh, and that is all she heard. It was on repeat on MTV on the TV, was staring at ceiling tiles and hearing this laughter. She did a lot of work. After coming home, her husband, John, ended up being deployed. Guess who he was deployed with? Kim, their CRNA. So they meet on the ship. They talk about their shared perspectives. Kim shares how difficult that day was for her, how she's been wanting to know more. So off she goes on the ship. Her and John become fast friends. She earns the title of Auntie Kim. And now we come back, John comes back from deployment, and guess what Olivia's been doing? She's been emailing me, and she's been asking me 1,000 times, what's the data for subsequent deliveries? So after a lot of work, EMDR therapy, they decided together that they were going to go for another kiddo. So they went for broke, and they scored big. She won the lotto. She had a subsequent delivery, a beautiful little girl, Rose. But this is the picture on the right, which is Olivia, and what you can't see is how traumatized she is despite all of that work. She is in there, and her and Kim had talked deeply. All they wanted was Kim to be in the room that day. But what they talked about was, how do we cover the ceiling tiles? Because I don't want to see them again. And I also want to be able to see the faces of the team, because if the stuff goes down, she's going to have something to say about it. So she had a clear drape so she could see the faces of the providers, and she had a sheet over the ceiling. And I just share this moment with you because I think this is such a telling moment. Kim has been involved with our organization now. Their bond is forever. Kim goes to the birthday, we all go to the birthday parties. Like, she has truly earned the aunt status. And so oftentimes when we talk about anesthesia and your connection to the patient and how brief your time may be with that patient, I also recognize how profound these events and these moments are. We do a lot of caring for the carers. This is a series of pictures that somebody had taken that I wasn't aware of, but I gave a lecture, and afterwards there was a line of people, and I think all they wanted was a hug, which I'm here and I will give hugs. I mean, we can do a line here, we can do a conga line, we can do lots of things, but I'm willing to give hugs. So there was this woman in line, and now I'm, and so the point is that people just want to be heard and validated. Providers have stories too, and there's really not enough space for that. The bottom picture is a picture of a team in a very rural Upper Peninsula in Michigan. They had faced a loss. We supported this team right away. A long litigation later, and things finally were settled. There was no fault, but the team was so traumatized. And I found myself out at the NIH. At the time, it was in Detroit, and I was like, how far is this drive? I should go see, because I think you could get anywhere in a quick amount of time. Drove up, met with them, told them I was going to be in town. Their entire team showed up from that day, including their anesthesiologist. We sat in a boardroom for 2 hours, and I essentially asked them, let's talk about this. Tell me this is a safe space. And there were tears, I think, from just about every person. And afterwards, there was like an audible, like they had let their pants out after, Thanksgiving. You could tell that they needed that time to reprocess it even years later. So when I'm saying, and May, I know that you had me come up to talk about how can we heal after these and how can we work together and collaboratively with patients, always centering the patient. And I thank you for this time, but I want to share, I'm not alone on this island. There are many organizations out there that have been founded by survivors or family members. The Accreta Foundation, the Preeclampsia Foundation, the Hyperemesis Foundation, Sepsis and Sepsis, the Rory Staunton Foundation, Sisters with Cardiomyopathy. There are so many amazing organizations. And so I just share, you can reach them through Mama's Voices, which is the coalition a few of us co-founded to help connect providers to patients. And then lastly, I just wanted to end. On the left is Dave and I. At the bottom is their son hugging my son. And both of our boys are learning how to drive, which is terrifying. I think he's been trying to take me out literally since day one, because I don't think my heart can take this. But all that to say is that I wanted to end with this, which is it has been a privilege to do this work for 17 years, and it's been a privilege to share these stories with you. I have countless stories, but I thank you all for your time.
Thank you so much to all the speakers. That was really incredible. We're a little bit behind, so we're going to delay our questions for the next session. We're going to take a really quick 5-minute break, very short, and then we'll come back for our next panel. Thank you.
clip that, right?
Yeah, that one's forward,
That's a
that one's
big
back.
deal.
And then
Okay.
that's the laser pointer.
Okay.
I think if you point it down there, it's okay, but. All right. You ready? Lynn, you ready? I'm ready. Okay. All right, if we can have everyone's attention, we know that that was a very short break, but we have an exciting final program for the afternoon. So we want to welcome you back. Keep all that energy. So as you all make your way back to your seats, I wanted to mention, in the spirit of keeping the dialogue going between clinicians and industry, that 2 of our corporate sponsors or supporters have some seats available for their focus group. So there are 2. There's the BD focus group this evening, and the topic is closed loop infusion therapy, and that's at 5 p.m. in the Indiana room on the 3rd floor. And then there's another focus group tomorrow morning, the Solventum focus group, and their topic is challenges with achieving normothermia. Every patient, every time, and that's at 6:15 in the morning for the early risers in the Kimball room on the 3rd floor. So if you're interested at all, Stacy in the back can give you more information. Otherwise, I'm going to turn things over to Lynn, who's going to spearhead our final set of presentations for the afternoon. Thank you.
Good afternoon to all of you still here and to the 20 folks who are online with us. It's so good to be with you. I can't believe we're going to be talking about our 5th session already for the day. It's been such a incredible panels and panels and panels. But now we're going to talk about intrapartum challenges and emergencies, including pain management during cesarean section. I have 4 speakers that I'd like to introduce to you quickly. You can see the rest of their bio inside the program online. But Pian-Smith, one of our co-planners, and so much more in my heart, she's going to talk with us about communication and trust among teams and with patients. She's an obstetric anesthesiologist. I took the senior off because we don't want to talk about being seniors. At Mass General Brigham, she served as the MGB Enterprise Director for Anesthesiology, Quality, and Safety for many years. Her research is focused on speaking up across hierarchical gradients, and if you've ever had the opportunity to work with May, she has a very quiet way of bringing everybody back to center and talking about difficult topics respectfully. Heather Nixon is going to talk with us about inadequately treated pain. She's a division chief for obstetric anesthesiology at the University of Illinois Hospitals at Chicago. She served on the Illinois Maternal Mortality Review Committee for 6 years, and she's been featured in the New York Times and serial production, The Retrievals Season 2, right? And her quality improvement and safety work in the clinical area, intraoperative pain during cesarean section, with all of you who have experienced that, trying to take care of a patient during that experience. It's a challenge for sure. And then Kokila Thenwara is going to talk with us about simulation for addressing challenges. We exchanged conversations about our colleagues from the University of Iowa, where she's a clinical professor of obstetric anesthesia. And if anyone is from Iowa, you know about the force that the University of Iowa is in community simulation. She is the chair of the Subcommittee of Simulation-Based Education, supported by a HRSA grant, and she's appointed member of the Iowa State Maternal Mortality Review Committee. And last and never least in my heart, Alex Hannenberg. He's going to address obstetric crisis, boy can I talk, with digital obstetric crisis checklists. I first met Alex doing the emergency manual checklist, and those cognitive aids have become so important to practice to team management of crisis. He has served as the ASA Chief Quality Officer. He's a senior research scientist and core faculty member at the Ariadne Labs, focused on surgical safety programs, including checklists for critical event management and team-based case review implementation. So with that, I turn it over to May to get this panel rocking. Thank you.
Thank you, Lynn. That's so wonderful. Hi, everyone. Congrats for hanging in there. I'm really impressed by the size of the group that's still here. I am very much respectful of your time, so I'm going to try to move things along quickly. We want to keep our promise to you that we will be done by 5 because we have a great focus group planned for that time. So I was kind of surprised and happy, actually, that in many of the presentations so far today, the word trust has come out. I was trying to keep track, and actually I think that more than half, the majority of presentations spoke something about trust. And I think one of the reasons why we're so focused on it is because we're trying to figure out that missing link or that miracle or whatever it is that's needed to connect all our great ideas and our recognition of challenges and gaps with solutions that are scalable, impactful, feasible, et cetera. So maybe this is one of the ingredients of that secret sauce. Yesterday at our Board of Directors meeting, we were talking about how proud we are to offer funding for grants through APSF. And there was a little bit of a complaint that we never hear about whatever happens. And so I'm here to let you know that this is my disclosure slide, that actually I myself was a recipient of an APSF grant looking at trust between surgeons and anesthesiologists. How crazy a topic is that? But we completed, I would say we're in year 5 now of a 2-year grant. And we are very pleased that we interviewed 40 practitioners across the country in all different kinds of practice settings. And we just completed 2 manuscripts that are going through the review process. So I'm really hoping that you'll be seeing that very soon. And I will pull in a little bit of what we learned in the course of that project in this 15 minutes. So communication and trust. I want to say that we know we have problems with this. We don't always do it well, but also these are our opportunities for learning and for improvement. As Lynn mentioned, I've spent many years looking at reviewing cases where things maybe zigged and zagged and didn't end up the way we had hoped. And when we review them, of course, we're looking for precipitating events that may be targets for improvements and to sort of keep our promise to our patients and to our colleagues that we don't want this to happen again. We want to learn, we take seriously what happened. And when we do those reviews, we find that most of the time they're very multifactorial. But one of the very common themes that seems to come up everywhere is this idea of communication or a lapse in effective communication. And what I find very sad is that when we really look into it and we interview people, we find out that actually, most of the time, somebody in the room knew that something was wrong, but for whatever reason, they couldn't speak up with it, and they couldn't facilitate having a shared mental model for the team so that the team could work collaboratively towards a solution. And so this has actually become a research focus for me, this idea of speaking up. Why is it so hard? Why, as Amy Edmondson says, why do we self-censor ourselves in these critical moments? And why do we do this calculus that somehow makes us feel that the risk to ourself in the moment is greater than the potential risk to a patient? And so I think that this is an area where maybe we can move the needle. So despite our best intentions, errors will happen. And we often make the example that we don't wake up in the morning hoping that we're going to do something awful or make a terrible mistake, and yet somehow things happen that way. Luckily, not every day, but they certainly do happen. And I think the reason why this happens is because we are bright, we are well-trained, we are well-intentioned, but we're also very human. And the systems that we work in aren't always ideal to help support us bring our best to our efforts every time. One thing that I think also trips us up is the cognitive biases or the heuristics or mental shortcuts that help us act in very expert ways. Through our training in healthcare, we learn how to recognize patterns. We can quickly intervene in critical situations, but also those kinds of mental shortcuts trip us up and sometimes lead us to errors. And a lot of people are familiar with Daniel Kahneman's work on fast thinking and slow thinking, type 1 and type 2 thinking. A lot of what we're thinking about, we don't even realize we're thinking about, and so we don't even know how we can improve or how we can refine our thought processes. So one of the reasons why we have to really work on communication is that communication not only helps our patients, but it helps ourselves. So Amy Edmondson has reported, she's studied this for years and has published, about how the quality of communication is a marker of psychological safety. And the example she gives is in a particular hospital, the number of safety reports about things going wrong suddenly shot up. The first reaction was, oh my gosh, what's going wrong in this place? And then she helped people realize that no, that means that the new leadership that's here is providing a safe space where we can talk about what's going on, and it's only through that kind of recognition that we can even have a chance to learn, to study, and to try to make improvements. And then there's sort of this cycle thing that happens where once we improve communication, that then is a driver and mechanism for further improving safety culture. So lots of reasons why we should be working on this. Today we talked about scaling up things that we want to do so that they have real impact. And here we've got all these brilliant ideas, great packages and bundles. How come things aren't really, the needle isn't being moved? And we realize that we're actually in a much bigger ecosystem, right, with a lot more going on, and that distrust is a barrier to dissemination of best practices. If the patients aren't believing in what we're talking about, if they're not engaging with our recommendations, then we don't have hope for better improvement. So individual and systemic distrust affects access to care, management, treatments, and ultimately our outcomes. So one of the constructs that I learned about in doing our APSF-funded study was this idea of relational coordination. Some of you are nodding, I think you're familiar with it. It's a construct of interactions that has been formulated by Jodi Gattel, who is a social scientist based at Brandeis University in Boston. And basically, she's studied relationships, she studied ways, behaviors that seem to foster better relationships. And she's in particular studied how this all works in all different kinds of industries, including healthcare. So she's brought her teams into ICUs, labor and delivery units, and that sort of thing. And basically, she says that relational coordination is something good that we want, and then it has two components. Good quality communication, but also connected to that, so it's not just checking off boxes, but good quality relationships. And the way she further drills down and describes these is that good quality communication is frequent, timely, accurate, and problem solving. And when I think about it, isn't that exactly what you want from your colleagues when a patient is hemorrhaging to death or rapidly spiraling with terrible sepsis? And then in addition to that, good quality relationships she describes as having these key ingredients: shared goals, shared knowledge, and mutual respect. And these are things I think that could only foster long-term trusting communication, not only between us and our colleagues, but also with our patients, which we have said in multiple instances today is going to be key for us to really transform our outcomes. So, normally when I talk about this stuff at medical meetings and at anesthesia conferences, I feel a little bit embarrassed because it feels a little bit fluffy and foofy. And I don't have like amazing graphs to show like some of the speakers today. But it turns out there have been many studies that have shown that actually relational coordination, when you get it right, gives you the kind of outcomes that people care about. So these are the kinds of things that hospital CEOs care about, or boards of directors care about, people who can measure and appreciate return on investment. So these are documented in studies. Improve patient satisfaction, decrease length of hospital stay. I think everyone here is hearing about that and having to deal with that. Mitigated harm from inevitable medical errors, mitigated harm from peri-op adverse events, and decreased rates of infection. So these are all things that burden our system, they burden our workforce, and they cost us money. Another way that she has studied relational coordination has to do with what happens when you don't have it. And these are things that I wanted to list because I think they're really important to the safety science and the patient safety folks in this department, in this area, in this room. These are all things that we recognize as being bad and real threats to helping us accomplish what we want to do. So worse performance on individuals' tasks, decreased adherence to safety protocols. So here we are, we've come up with these bundles and nobody's following them. Worse team performance during critical events. More and more we're realizing it's not the value of one brilliant team member, but it's how we all show up together. Decreased worker morale, increased disability, increased workforce turnover. So these are all things that are making our job really hard these days. It's really hard to be a human taking care of other humans right now, and it's getting more and more expensive. Especially during the COVID epidemic, we realized that having relational coordination supports a lot of the key things that really help us show up, be resilient, and in many ways thrive. And a lot of it has to do with the connection that we have with other people in our orbits, connections that are more hardwired by practicing elements of relational coordination. So there have been studies that show increased resiliency, decreased clinician burnout, increased job satisfaction and engagement, self-efficacy, innovation, courage, and gratitude, all things that we like to believe we have at the end of the day as we go off to bed. So this is a slide I added about how we want to think about incorporating these principles in our interactions with patients, because it seems to be that one effector arm is to sort of make things better between ourselves, but another effector arm is to try to apply some of these principles to our interactions with our patients. So as you've seen in other presentations, respectful maternity care. Turns out there have been studies that show that you can train to do this. So either with simulation or otherwise, we can get better at how patients perceive us in these interactions. And this improves patient safety and experience. We need to take advantage of collaborators such as trusted messengers. So for example, community doulas. A lot of this is in the midwifery literature, it turns out. Community doulas improve outcomes, prenatal care, and also continuity of care after delivery seems to be improved by engaging our community colleagues. And also language access. So professional interpreters do improve safety, and patient navigators boost postpartum follow-up. So just yesterday, actually, I had a conversation with Jen Banayan, who, I hope it's okay that I share this, was talking about how frustrating it was to shepherd her own mother through the medical system. And here she's, a pretty medically savvy person, and we were thinking, wow, how awful is that then for people who don't have people plugged into the system already to help shepherd them through. So definitely this is an area where there are opportunities for improvement. So I wanted to summarize at the end with a little bit of a toolbox, if you will. Anything we can do to promote shared mental models. So in our own institution, we're doing a lot more simulation and training during, not only for residents and trainees, but also for faculty about sharing, being very transparent about our thinking, reminding people that people can't read your mind, especially during a crisis where maybe you are speaking less and trying to think and act more. So we're being very deliberate about how we share our information, encouraging closed-loop communication so that it's not just that you said something, but it's that you were heard and you were understood and you can move forward together. And rapid debriefs, so not waiting too long, but sharing the understanding of a situation right away so that learning can be very appropriate, and also identify, for example, if there are devices that need to be sequestered because of a bad event, medications, and how people are doing. And is there anyone who really needs to leave the hospital or a clinical setting for self-care or for peer support and that sort of thing. We're realizing that, sometimes this is hard to do on our own, so our institutions can really help us by hardwiring some of these things. When we do huddles now, we have shared with our surgeons, for example, that it's to their advantage to use this opportunity to invite people to speak up during the case if they see something. See something, say something. And so it's becoming more commonplace for a surgeon to say, hey, this is fourth time C-section, and the ultrasound of the uterus is a little bit suspicious. I'm not sure what kind of bleeding situation we'll get into, and so definitely speak up. Just hearing that from someone really helps other people in the operating room contribute to a shared mental model about the safety situation. It helps people work together. Also, we're teaching, by the way, that if somebody speaks up, if somebody takes the personal risk to speak up and they're wrong, you need to thank them for speaking up, because there have been studies that show that once you say something, take that personal risk, and are squashed for it, you'll never speak up again. So we try to convince surgeons it's actually to their benefit to have people help them. So anything we can do and make part of our standard everyday practice of how we do things will help solidify this kind of safety culture. For example, using surveys, just culture, algorithms, and promoting psychological safety by really having transparency about what's going on, what's learned, sharing the learning so that everybody can benefit, and then therefore there's value to sharing when things don't go well. In terms of patient partnership, we've heard today about the importance of doulas, group prenatal care, continuity models, community boards, and doing everything we can, including with technology, to improve equitable access to the best care that we can offer our patients. So Elliott was saying, what do we do when we're trying to get trust in 5 minutes? So I've been thinking about speed trusting. And in our papers that are hopefully coming out soon, we have some sample language and sample things that we think might be helpful. But today, I wanted to share with you something that you can enact tomorrow or next week or the next time you have some patients, or maybe even when you're talking to your teenage children at home. So, we always pat ourselves on the back when we use the golden rule, right? And our goal is to be very respectful, and so we treat other people the way we would like to be treated, and nothing less than that. And I want to encourage you to instead perform the platinum rule, which is to treat others as they would like to be treated. And in order to do this, you need to take a pause, and you need to appreciate that their values may not be the same as yours. They may not be coming from the same emotional or physical state as you. and you're taking a moment to figure out on your barometer where they are, what's meaningful to them, will just put you in such a better position in terms of instilling trust, being respectful, and continuing a shared decision type of conversation. So I just wanted to leave that with you. And also, you know, this is my last slide. I want to thank you guys for making a difference. You know, I want to make the point that speaking up, teaming, trusting, these are a competency, right? We should be training for it. We should be practicing it. We should be seeing how we're doing it and measuring the impact of these communication and trust issues. It's good for our patients. It's good for us. And this last click is something that I learned from Jeff Cooper, who, you know, we can't have an APSF meeting without talking about Jeff Cooper. He likes to challenge his audience to put into action whatever it is you've heard about today. And so I want to ask you guys, how do you or will you incorporate teaming, talking, and trusting into your work? This is my email. Take a screenshot of it. If you send me an email in the next 30 days, I, first of all, would love to read about it. And I'll do a hand lottery and randomly pick someone to get a $50 gift card. So thank you.
Thank you, May. Good afternoon, everyone. Thanks for the diehards who are sticking in here. So it's my honor to really talk about a topic that's near and dear to my heart, which is pain during cesarean delivery. Some of you may know some of the things I'm about to talk about. Some of you may know nothing about it, so I kind of incorporated a little bit of background in here. But we'll just get started. Okay, first off, I have no financial disclosures to make, but I have a couple fun disclosures. Number one, 25 years ago, I did work as a bartender in this facility, so it's good to come back in a very different role, because I did bartender here for years. I know, you're welcome. And secondly, I am post-call, which means if I make mistakes, please just clarify in the questions later. And also, I did add some audio clips, which just increases the level of difficulty, so have some patience for me and my cognitive load of post-callness. All right, so we're going to talk about the learning objectives quickly. We're going to explore the topic of pain during cesarean delivery. We're going to talk about some of the contributory factors, and I think this is where the bulk of what I'm going to talk about is today, and what I've really learned in the last couple years. And then we're going to explore some solutions, but I'm not going to spoon feed you on those. So many of you have already heard about this. Many of you may have listened to this. Maybe some avoided it. Who knows in the room? But The Retrievals is really a podcast via the New York Times and Serial Productions that focuses on women's pain and undertreated pain. And season 2 aired in July of this year, and it focused on pain during cesarean delivery. I put 2 figures up here who are prominently figured in the series, and this is Susanna Stafford and Clara, and I'll just use Clara because of her last name. Nobody ever uses it. I know her personally. But they really were 2 very brave souls who shared their stories and really brought to the forefront what's happening in ORs across the country and some work that we have to do. So we'll start with Clara. The episode 1 starts with Clara's story of her delivery. Now, full disclosure, she is a labor and delivery nurse who works at the University of Illinois, which is where I am from. So I know Clara very personally. She comes in for the induction of her labor. She has a twin gestation. The obstetric history, not really relevant in this case, except for the fact that she gets an epidural, which I place. You'll find that out in episode 1 as well. And then I leave and she has to go for C-section. So as she goes in for C-section, some things happen that really highlight, kind of some of the cognitive misses we can have as providers. So she's dosed up with her epidural. She gets 2% lidocaine with epinephrine and bicarb. She is prepped on the OR table. They do the skin prick test, which we institutionally do with a toothpick, basically, or kind of a tongue depressor that's broken off. She passes that with flying colors. They do an Alice test, which if for anyone in the room or any patient advocates in the room, what they do is the surgeons will actually take a clamp and go along the incision line, make sure the patient's numb. She passes that as well. Unfortunately, she starts to have some, what she thinks is anxiety. She really doesn't feel well. And so she decides that maybe she'll get some anti-anxiety medicine because she's feeling uncomfortable. But it soon becomes really apparent that she's starting to feel intense pain. I'm going to see if I can get this first audio clip to play.
Clara's anesthesia is not working. She is now in the middle of major abdominal surgery, and she can feel that surgery. Clara knew this could happen. She had seen this happen. Intraoperative pain during cesarean. Healthcare providers know about it. Patients don't. When Clara herself first started working on L&D, and patients in labor would tell her, "For my last baby, I had a C-section and I felt everything," Clara would think to herself, "That can't be true. There's no way. Who would do that?" And then she saw it happen. And now it is happening to her. Visceral, that key word. What Clara is feeling is visceral pain, meaning pain that originates inside her abdomen. When the doctors did the skin test, Clara didn't feel it, right? She was numb. But sometimes a cesarean patient is numb when you test her skin, and when you open her up, you find she's not. There are a lot of reasons for this, but in the moment, the reason for the pain doesn't totally matter. What matters is that you treat it.
So in this operating room, she's experiencing intense pain. She continues to stay awake for the procedure. She's given 300 of fentanyl, 60 of propofol, 0.8 of Dilaudid, 6 of midazolam, and 32 of dexmedetomidine, which, for relevance, if you're not in the anesthesia world, is a huge amount of IV sedation. Despite that, she's moaning, she's screaming, she's saying, "Help me," and her partner is sitting next to her. So following the surgery, she clearly is traumatized. She's experiencing signs of PTSD, she's having flashbacks, and she's having difficulty returning to work. So it's pretty much undeniable at this point, with the amount of publications that we have, that ultimately we know that pain during cesarean delivery is real. It's a phenomenon. It hasn't been well defined, but patient stories are telling us that for some patients, it's very traumatic, and it's not the experience we would ask anyone to have. Now, I told you that I've been thinking about this a lot, and so I kind of summarized what my thoughts have been in the last 2 years. I've been lucky enough to kind of be in this space for a little bit. Clara's surgery was in 2022, and at first, when I heard about this, I was furious at the provider. I was so mad I couldn't even see straight. I was pacing, I was angry, I was sweating. And I had to talk to this individual, and all I wanted to do was slap him. Now, it's not a very mature response, I get that. And as a leader, it really wasn't the right response. But it's how I felt. And when I talked to this individual, I realized that there was a perspective, and there was dogma, and there was kind of hidden ideas that I really didn't understand that are influencing the way providers practice. So I want to take a moment and talk a little bit about all the lessons I've learned in the last couple of years from talking to providers, talking to patients who've contacted me, and also even just listening to the podcast. Although I was in it, I really didn't hear the entire product until the end, and I learned things. I thought about new things as it came out. So first off, Neuraxial is not always enough. We have a patient here who passed her skin test, which is our best metric of can we proceed, yet intraoperatively had tremendous pain. There are 2 types of pain that we have, somatic and visceral. You heard Susan talk about it. Not all of our neuraxia will block the visceral, and that is where the problem starts, because we are testing the skin. And so we have providers who stay the course and say, "She's numb, I've tested her, her block is working," even in the face of a patient who's moaning and screaming and saying it hurts. We don't see it as pain because it can't be, because it's the skin, and that's just wrong. We have to change that culture. Secondly, this idea of failed, and in the literature, failed neuraxial. This is an expected outcome that some blocks will not be dense enough for abdominal surgery. And we have to accept that as a risk. We have to know that that's not failure, it's only failure if you don't treat it. So we have to change it to inadequate analgesia, inadequate or unoptimized analgesia, and we can do things differently. And this, in our system, led us to look really deep in the literature and figure out how can we densen our blocks. And we made it mandated that in our unit now we use fentanyl and clonidine along with local anesthetic in all of our blocks in order to really hit every receptor we can before we say it's inadequate and we have to convert. The ASA has done some great work here, right? They've published some really great statements, and especially the use of adjuncts during cesarean delivery. But really, this is a punch list of things you can use. It was meant to normalize the idea that we can give pregnant women during a C-section IV agents to help their pain, and that it's okay to have general anesthesia. But it is not an algorithm. There is no information for providers to use to say what to do where. And that's the problem, because there's no teaching in this. There's no textbook I can give you in this. I've searched, I've looked for algorithms, and no one has this. We all learn by role modeling, we all learn by talking to individuals, and many of us have it wrong. So it's not a surprise that this is happening. Next, we have bias. So there's a couple things here. When we talked to the provider, and I talked to the provider about what was going on, again, he had some really enlightening things to say, and I just want to play that little clip of me discussing my conversation with him. Can we play it? It should be in the corner. Let's see if I can get it to go. Okay, we'll skip that one. There you go, thank you. He kept saying to me, well, she has anxiety, and so we kept giving her like anti-anxiety medicines. And I said, but she was telling you she was in pain. And he's like, oh, well, she had anxiety. She was just very anxious.
The anesthesiologist had repeatedly mislabeled Clara's pain as something else.
It was also, well, the patient was having a lot of pressure. And that's when that word really became a dirty word to me. I was like, yeah, but no. So we saw that this provider said she had anxiety. That's why he gave her 6 of midazolam to treat her anxiety. She also got nitrous for anti-anxiety, which she had requested, and that was okay. But what we find is that there are providers who attribute patients' pain, especially women, to anxiety, and that's not always true. So there was a really smart study by Keltz et al., and what they did was they took patients, it was a prospective observational study, and they took patients, and then they took anesthesiologists and OB providers, and they debriefed after C-sections, and they asked patients how many of them had pain intraoperatively. We found about 12% of the patients had pain. Doesn't talk about severity or any of those things or where they had pain. But when we surveyed the OBs, it was about 4-5% of OBs thought that patients had, or they thought 5% of the patients had pain. So they were missing a significant number of patients, right? Well, what about on our side of the drape? What about on the anesthesiologist side of the drape? Well, we thought it was about 16%. So we did much better, clearly. However, our number of false positive and false negatives was unacceptably high, which means we attributed pain to anxiety more, and we missed patients who had pain. So we're terrible at this, and we just have to accept that without asking a patient, we have no idea what's going on. In my clinical practice, with some of the systems we design, I've really found that this to be 100% true. So we really need to take anxiety out of the picture and talk about pain. We need to teach our trainees, we need to teach our providers that there are 2 separate questions. Are you having pain? Are you anxious? They are 2 separate things, and we do not treat pain with anxiety medicines. If we look at overall numbers of pain during cesarean delivery, they vary widely. Now, why do they vary? Well, they vary because if you survey the literature for studies that have used surrogate markers, including conversion to GA and the use of IV adjuncts, you'll see very low numbers. Why? Probably we're missing that patients have pain. But if you ask patients, you're actually going to see the higher numbers. So let's take those as the real numbers. Let's say that that's real and not what we think, because we know we're terrible at this. So we're talking about 33% of patients who have an epidural may experience intraoperative pain. That's 1 in 3. That's a huge number. That is the highest risk factor you have going into an operating room from anesthesia, and we don't talk about it with patients. That's a crime. So what did we do to change this in our own unit? Well, we started working on communication a little bit, right? And so what we found is that our communication with patients is really poor, right? We're not asking questions the right way. We're not using language that empowers them. There's a hierarchy that is described, right? And patients want to please us. They want to get it right. They're thinking about their baby. They don't want to delay care. And so they often may not tell you exactly what's going on if you don't ask the questions the right way. We can play the clip, please.
The anesthesiologist repeated the same test and the same question multiple times.
It was very clear to me that I was not answering the question correctly. And I'm the sort of person who likes to answer questions correctly.
Susanna was lying on a table, looking up at the anesthesiologist. She was aware the room was full of people who were waiting to begin. She felt embarrassed by the amount of time she seemed to be wasting. The anesthesiologist asked again if Susanna was ready. This time she said yes.
And I knew I had given the wrong answer when I felt the first incision. And that felt like I was a beanbag being opened up.
So you have a patient who's very, very a self-advocate. She describes herself as such. She is informed, she speaks English, she's in the UK, she's with a provider of her own ethnicity, and she couldn't tell the providers, no, I feel pain. She felt embarrassed to do so because they kept asking her, well, you're ready now, right? You're ready now. And she describes this in detail in other settings, and she has videos on this as well. But ultimately, we're missing the mark with getting the information from patients. Another lesson I've learned is that it's not always dismissal of pain. It's not always communication, but fear drives a lot of our choices. So I'm going to play a clip that's from a SOAP 2023 lecture that I gave where I kind of crowdsourced and I asked the audience kind of what's causing this? And there was a very senior member of our audience who came up, very seasoned, and his comments were very enlightening.
So that, for me, it's not just about, oh, the patient's comfortable or she's just exaggerating. It's sometimes that fear that if I do get into a general anesthesia, no one knows how to help me.
Sorry, that's the second clip. There's another clip. Can you play that one?
When we think about why this happens, I think there is this specter in the back of our heads that says, oh crap, the spinal's not working. If I have to induce general anesthesia, there's a chance, because we all have PTSD, that the pregnant airway is horrific, that I'm gonna lose the airway and the mom will die. And I think that is what is, I mean, I'm gonna say it, that is a fear of mine, that I will lose the airway, and then they'll be like, well, yeah, she was uncomfortable, but maybe you could have muscled through and at least she'd be alive.
So you hear that fear of losing the airway, fear of oversedating and losing the airway, fear of impacting breastfeeding, fear of being judged, right, as well. That's kind of come up with, we're using metrics for GA that maybe aren't really allowing our providers to feel empowered to make that choice. They feel that somehow that's the wrong choice. And then the first clip that we heard, it was a provider in community practice, and that's become more important to me lately because I work in a community practice for part of my call, where she didn't feel like she had the right resources. She didn't feel like if she got into trouble with the airway, there was anyone to help her, or even just help her start, right? Depending on where you practice, that may play a really important role in why you're fearful. It's not that you don't know how to do an airway, but you have no one to hand you stuff, no one to assist you and make sure that it's done safely in the same way that you might in the main OR. Not all of our nurses on L&D are trained. Next, I've learned that fear, there's a lot of focus on the fetus. that this really comes into play, right? There is this coercive language we use. Well, you know, we're gonna make sure your baby's okay. We have to deliver you now because your baby, your baby has to be delivered. You want medicine after the baby's delivered. These may be impeding people from asking the right questions intraoperatively or treating appropriately. And this really comes into, the pervasiveness really comes into a quote from Susanna, one of the patients, that I would like to play next.
So when the community midwife came to visit me, I tried to say something about, you know, the operation had been a bit traumatic. And she went, "Oh, never mind, dear, the baby's all right, that's all that matters."
So you can see, your baby's okay, that's all that matters. And for a lot of women, that is the outcome that they need, and that is the one that's most important to them, and it does impact their experience. But we have to strip away this idea that every decision a woman makes when they're in labor should be in service of what's in their uterus. They have the right to be comfortable, they have the right to be respected, they have the right to get good care and have a good outcome with their child. And I think that's so important because there's no other part of anesthesia that anyone has to make that choice. No one has to make a choice between their knee and their child. And it's a part of the language that we use that we have to strip away. It's coercive in nature, and it's developed over years, and it's societal, but we have to recognize it. And then culture, don't cross the drapes, right? One of the things I said in the SOAP lecture in 2023 was, one of my proudest things is that I have a unit that trusts their anesthesiologist. They love us, they consult us, they trust us to provide good care. But it was one of the biggest downfalls in the case of Clara, because everyone in the room knew something was wrong and no one challenged the anesthesiologist. It was anesthesia's job. Don't cross the drapes. They're responsible for that. And that's a problem. We need to pull that curtain down. We need to make it a team-based play, and we need to have all the same shared mental model. So what kind of language do we do to normalize pain? You hear these things like, is it just pressure, right? Just pressure makes it sound like that's okay. It's normal, right? Again, one of my favorites. It's normal to feel pressure. Nothing about pain in there, it's pressure. And then finally, it's almost over. So what we're telling our patients is bite the bullet. What other surgery do we do that in? Never. We never do that. And this is something that happens again and again and again in the OB realm, right? Why? We don't understand it. It doesn't make sense. Is it because birth's supposed to be painful? Is it because we're uncomfortable with alternatives of treating the pain? Maybe. And then finally, if you don't believe me that culture plays a huge role, I want to play this next clip for you. And this is one of the nurses who was a friend of Clara's, who was in the room at the time that she was delivering. Thank you.
And it wasn't until she just kept begging, like, please, please, please. And one of the attendings, she looked at me and told me to tell her that it was okay. She told me to tell her partner, please tell him it's okay. So at that moment, I was no longer a friend or like an advocate. I was more like a staff member being told by the doctor, like, it's fine. So I remember telling Clay, like, Clay, you know, this is normal. This sometimes happens. And Clay, I remember his body language was very like, yeah, okay, like, I hear you, but don't talk to me. And I remember being like, oh my gosh, because he was so stressed out.
So what else do we see, right? What else do we see? Well, we see the consequences, or now we're starting to see the consequences. This is something I've really learned. I didn't know. I did not know what was happening to women after they left my care. I didn't know that the long-term consequences were preventing them from future pregnancies. And so Tracy already spoke about trauma-informed care, but she was also at that SOAP meeting in 2023. And I'd like to play her clip, just the summary, because I think she's going to say it better than I possibly could of what it looks like for these patients. Let's see if we can play the clip. Thank you.
I can't stand here and overemphasize the impact that this has on individuals their relationship with their babies in the terms of decreased bonding, decreased breastfeeding success. You mentioned the husband in this room. The impact on him, on the partners, on their relationships. Believe me, I've worked with so many women. I hear 11 traumatic stories a week. These are individuals that go on to get divorced. They can't even care for themselves. It rocks relationships. The mental health complications, I have women who are still having suicidal ideations years later. Their birthdays of their children become nightmares. The impact is so severe. I can't stand here and
So we've talked a lot today about implementation science, and one of the branches on that was, what's the data, is it supportive, right? Grace came up and talked about this beautiful project she's doing, which I'm so thrilled that she's doing. But those things take years. Those things take years to do, and sometimes you don't have the initial data to say what you're doing is different. I couldn't wait. I had an individual in my institution who got harmed. I had an individual who I had to bring back to the operating room for her first C-section and watch her panic as a patient said she was feeling something. So I couldn't wait. So we made some changes at our institution. I just like to quickly run through them, and I know I'm going to go a little bit over, but I'm hoping that you'll be gracious on this one. Sometimes you need to do, and then you need to figure out what works. And when you have this many patients who are potentially at harm, I think that that's the right move. You can't always wait for the data, or some of the studies will never be done. I'll look forward to implementing them when they're there. So we have incorporated a pre-op discussion about the risks of anesthesia, right? And that includes not only neurological implications, not only post-oral puncture headache, but the most common thing that can happen to them in the operating room, which is pain during cesarean delivery. This is not to scare patients, but it's to inform them, because it's an opportunity for us to now have the discussion of, you are in charge. Your pain is important to us, and we're going to be asking you about it. And here are the things we can do. Also, if you're anxious, we have things we can do. Here's the impact on the baby, here's when we can do it, and here's what it looks like. And it allows patients to go to the operating room more informed. Secondly, we have scripts that we give to all our providers, our OB providers to have with our patients in pre-op and during their prenatal care, our OB nurses, so they're not just saying, oh no, you'll be fine, the anesthesia is going to take care of you. And then for our anesthesia residents who find this conversation incredibly awkward, we give them a script, we give them words to use and language that we think really helps start the conversation. We have more precise sensory tests that we use. And what I say about that is, yes, we still test the skin the same way. Yes, we still do an Alice test. But if any patient has intraoperative pain, we actually do a skin test around the incision. We pull the retractor up, and then we manipulate the uterus, and we see where the problem is so that we can target our therapies, and it's not just she has pain. It is she has pain that is somatic, she has pain that is visceral. Where are we in the surgery? Can we adjust things? Can we move things? But our OBs know to do this full exam for us, so then we can talk about how much longer in the surgery we have. Is it right to continue to do IV medicine? Should we go to sleep? This allows us to have more information. We have some communication around pain expectations and intra-op communications. So there's a couple parts of the surgery that are painful. When you deliver the baby, someone's physically leaning on you. We can't block that fully. Most patients feel that. So we tell them that, and we give them the expectation that it will be a very short period of time. And our OBs will now warn us before that's about to happen, because they know the patient needs to know. They don't just start pushing on the belly without telling them. Number two, when they do the gutters, when they kind of do the upper areas and they're looking for hemostasis, they will warn the patient, you're going to feel something for a minute, but then it'll be over. And okay, is it over? Fine. Because a lot of times the patients do feel that. And if it happens to them suddenly and unexpectedly, they lose trust. They wonder if they're going to feel it again. But if we let them know, if we give them the timelines, if we act as a team, it goes much better. We've also talked with our OBs about surgical interventions. Number one, don't exteriorize the uterus. And so now my OBs stand there and they kind of look at me very furtively and they're like, we're gonna have to take it out. And I'm like, okay, like, let's make sure we're fine. Or they'll be like, nope, we're good, we're gonna keep it in. So they're training their next generation of residents to try to keep the uterus internalized. And secondly, we have the right to call their senior members into action. We know that the longer a surgery is, especially with spinal anesthesia, the more pain a patient can have. So we reserve the right to say, hop your senior in there. This is no longer a junior case. We need to speed this up, right? And I'll tell you, just having worked in community practice where the sections are all 45 minutes, we have much less pain than the 2.5-hour sections that I'm in my tertiary center. So we have to think about that as something that we have to push forward. We all have to say that that's how patients will thrive. Communication, we now have a very patient-centered communication, all right? And so in the operating room, we will again reiterate that pain is important, and we will let them know that every 15 minutes we're going to be monitoring pain scores because their pain is important to us, and at any point they want us to stop, they have that right. I tell patients you are not supposed to suffer during this surgery. There is no advantage of you suffering, but only you know if you're suffering, so you have to tell me. I try to enable that. We have translators at the bedside the entire, like in a phone, the entire surgery if we have someone who doesn't speak English to enable this. But as I said, we monitor pain scores every 15 minutes. If the score is higher than 3, our providers have to stop the surgery and do some form of intervention and have a conversation with the patient. And you'll see on the bottom there it says patient's reflections or patient's comments. We actually record what the patient is saying because some of them will say, it's a 4, but I want you to continue. I don't want anything. We put that in the chart. But 15 minutes later, we're back with that patient saying, do you want something now? Because we want to make sure that they don't feel like once they've made a choice, they're locked into it. And I think that that's really important. This has altered our outcomes tremendously in our operating room, and it gets providers to treat this seriously. Have our rates of general gone up? Absolutely. Education and coaching, we need to make sure that all of our providers know the right drugs to use and that our OBs are willing to wait the allotted amount of time. So we give them education on, if I need to put more medicine in the epidural, we're all gonna stare at each other for 5 to 7 minutes. We're all just gonna stand here. And they know now to be patient. If I need fentanyl to work through the IV, I say you're gonna need to give me 3 minutes until it's peak effect. We do not let them proceed. They know the timelines now, and they know that it's not magic, that what we have to do takes titration, it takes time. And so this is really important. And then we also use the data from our EMR to go back over cases where patients did have pain and say, did we use the right therapy? Did this work at this time? Should we have converted general? And then we have accountability. The entire team has the ability to call each other out, right? So May talked about this, speak up. It's very hard in these hierarchical systems, but now anyone in the room can say stop. And everyone does. Often there's a thank you, she's in pain, okay, we'll stop. And I think it's really changed the culture to allow us to catch up and to be really more mindful for the patient. We have debriefings, and so we ask, did the patient have pain? Was it treated? Should we have converted earlier? Was anyone uncomfortable with what happened, right? These are conversations that we have after a patient may have pain. Sometimes they have an unavoidable pain. Sometimes we're suffering through because the patient's like, I really don't want anything. But is that patient gonna have PTSD? Are they gonna be dissatisfied? No, maybe not if they had the autonomy to make that choice, right? So, and then finally, what I've really learned is the power of the media. We could have been in these conference rooms with 100, 200 people. I could have been on the circuit for, repeatedly for a year and a half. But there are millions of people listening to this podcast, patients, providers, spouses, right? And the feedback that we're getting from all the different various characters, because they've all reached out from different people, is that people are really happy that this is coming to the forefront. They're really excited that things are changing. They're really excited that they feel like they can talk about this. Some of the survivors of this are thankful because they thought they were alone in this, and to know that they weren't, to know that their experience was not singular, there's nothing wrong with them, is incredibly comforting, right? And we've had lots of groups reach out to do journal clubs, right? I know there was a group from South Africa last week when I was at the World Conference of Obstetric Anesthesia who basically said, we did a journal club on this as an internal group, and we looked at our process and how we think about this. And so I think it's a really healthy thing. So we need to learn how to partner with media to get the message out further, because we tend to talk to ourselves, and that is a problem. We need all hands on deck on this one. And then finally, I'm just gonna make one little plug here. We talked this morning about patient safety bundles. I believe this falls in the category of preventable harm. I believe that this is a real health risk. So I pitched it in 23, I pitched it in 24, and I'm pitching it in 25. Let's build a safety bundle around this. This is preventable harm. Thank you for your time.
Good evening, everybody. We're in the heart of downtown Chicago, and you're all here, so you're a very disciplined audience. Thank you very much for being here, and thank you to the organizing committee for giving me an opportunity to talk to you about the challenges facing rural maternal health. I don't have any financial disclosures. However, I would like to acknowledge the support of the Health Resources and Services Administration and other organizations that have supported my work in my home state of Iowa. So these are my objectives, but I'm going to quickly skip through that because we are short of time. So I'm a bit short here, so I sort of can't see over the podium. But anyway. That's okay. Is that one here? Sorry. Okay. All right. My apologies for being a little bit short here. So one of the biggest challenges that we face in rural healthcare is access to quality healthcare. No, I'm fine, thank you. Thank you. So one of the reasons is because of rural hospital closures. So that's happening right throughout the US. And in addition to that, the OB units are closing down. And you might ask why, and that's because OB units are very expensive to maintain. They need 24/7 staffing, they need OR, 24-hour OR facilities, and in addition to that, usually these rural settings, the volume of patients are pretty low, and most of them are, or some of them are Medicaid patients, so that the reimbursement is also in turn low. And this accounts for the difficulty in financial viability. And so it's always, if a hospital is in trouble financially, it's the OB unit that's the first to go. So that's one of the problems with rural healthcare. And when a hospital closes, you'll find a hospital is there, but there's an ED, there's ORs which do other general surgery, orthopedic cases. There'll be a med-surg floor, but there will be no obstetrical services. So that'll be remaining in the rural setting. So this is my home state, Iowa, and you can see that there's all the negative or the stop signs sort of are the closed OB units. In the past 20 years, over 40 OB units have closed throughout the state. And 14% of women have to travel for more than 1 hour to reach their destination where their planned delivery site is. So that's a significant proportion compared to 9% of women throughout the US that have to travel that long. So Iowa being a rural state, you can see that how much of a distance that women have to travel to their destination for delivery. So I'm going to skip over this because many eloquent speakers did talk about maternal care deserts before, but this is, as you can see, it is a national trend, and it's not only that, it is a global trend. So this is a recent study that has been just published just last month, and it shows the correlation between maternal mortality ratios as well as maternal care deserts. And the description is not really very reflective, but there is a parallel between the two. And the statistical analysis, of course, is significant, though you can't really very clearly see it on this diagram. So I'm going to go back to what remains, and what remains is the emergency departments with no supporting OB units in these hospitals where the OB units have closed. And the other level 1 hospitals, which are the lowest resource OB units, those are the other hospitals that are remaining in rural areas. So why I stress this is because these are all low volume hospitals, and let me tell you why. So some of the other challenges to direct patient care are that in these hospitals or these units, personnel usually have limited specialized training. And what I mean by that is you wouldn't get obstetricians here, but you would get generally family practice physicians who have had extra OB training. The low patient volumes, which I stressed before, that means that there'll be infrequent exposure to obstetric emergencies, and that means that there's difficulty maintaining skills. In addition to that, none of the specialists are in-house. There are no OB specialists in-house, and neither are there any anesthesia providers in-house. They're all outside, and they come in when needed. Now, during after hours, things get worse. So staffing is minimal. Now, when we consider a rapid response team, there'll be so many people coming in that we'd have to say, you know, some of you all need to go out. There'll be so many experts coming in. But unlikely, in these hospitals, usually a rapid response team is the labor and delivery nurse, the unit clerk, and maybe the house supervisor, and in addition, maybe somebody coming up from the emergency department. So that's all you have in a rapid response. That's all you have during an emergency. Now, in addition, other critical resources. When we talk about hemorrhage, we talk about massive transfusion protocols. In these hospitals, there's like maybe 6 units of O-negative blood. And you probably have your unit clerk who can either go and fetch the blood or go and do the laboratory investigations. You can't have him doing both. It's one or the other. So you can see that the resources are lacking in these level 1 hospitals. So this was the plight that my state was faced with. And this was in around 2019, and that was before we became an AIM state. So our public health department, as well as our OBGYN department, applied for a HRSA grant, and we got that. And I was a part of that I was a small part of that very large grant, and this is what I was tasked with. So I was told, okay, develop a education module so that you can help maintain clinical skills in these rural hospitals. So this was our innovation. We developed a mobile simulation unit that went right throughout the state, and we taught obstetric skills to our rural hospitals, as well as those emergency departments which were lacking in the OB units. So this is what we did. We did several needs assessments. We purchased equipment. We gave equipment to all our facilities. We trained trainers in each of these facilities. We designed a curriculum, and we physically visited all the EDs that didn't have OB units, and we visited the level 1 OB units. So that's the vehicle we bought, and I can tell you a billion stories about that. I was given a free rein on what I wanted to do with this, with this program, but I was not given a free rein on what vehicle I could choose. So this is a Ford 150 pickup truck, and I have to tell you, it was not my first choice, but it is Iowa. So Iowa and Ford pickup trucks and cornfields, that's where I come from. So Anyway, this is what we did. And I'm going to tell you a little bit about the curriculum. So for our emergency departments, we had to do didactics as well as skill stations, because our emergency department colleagues, they had either forgotten their physiology or probably didn't have physiology and anatomy, or maybe have not had that amount of training. So when we talk about fundal massage, then sometimes the question comes up, okay, where is the fundus? Or even, what is the fundus? So we really had to do didactics, pretty extensive didactics, before we went in and did the skill stations. So our skill stations were performing normal deliveries, active management of the third stage of labor, and really stressing on the uterotonics, and also recognition of postpartum hemorrhage, recognizing severe preeclampsia, managing eclampsia, and of course stabilizing and transferring the high-risk OB patients to higher care centers. Now, for what we did for the OB units was a little bit different. So we collaborated with our Iowa Perinatal Quality Care Collaborative, and we did our simulations in tandem with the bundles that they were teaching on for that year. So up to now, we have completed 2 bundles, the severe hypertension in pregnancy bundle and the obstetric hemorrhage bundle. And now we are in the maternal mental health and maternal drug use disorder bundle. So I was pretty successful in designing the simulations as appropriate for the first 2 bundles, but the maternal mental health bundle has been a challenge. It is very difficult to create simulations or even communications modules on this, because I am always conscious about triggering traumatic events in even my providers or even the standardized patients. So it's been a challenge, and actually my colleague Tracy has given me a lot of good pointers which I can use going forward. So the good thing about partnering with the Perinatal Quality Care Collaborative is that we are giving the same information to all the hospitals. So the care is standardized right throughout the state in Iowa. And not only that, the information is always up to date, and it is always best practices. So that's what, so instead of doing simulations just ad hoc, partnering with the Perinatal Quality Care Collaborative, I think is a very, very smart move. Standardization right throughout the state, I think that's key. So I want to tell you a little bit about the simulations. So the simulations were all inside too, because we actually traveled to the sites. And we used the equipment that were available in the labor and delivery suites, and we used their protocols. And now, I want to address the fact that the main OB providers or the anesthesia providers, they're not in-house. So we often stressed our simulations along with communication from for the nurse who's at the bedside, and we taught them to communicate with the providers who were outside. So essentially using S-bar as a tool to communicate and convey the condition of the patient to the provider who is outside, and get orders or whatever preparation that needs to be done, so that when the provider comes in, say for example, the provider wants to put a Buckley balloon or a Jada balloon, the nurses would be ready, would have that all ready, even the glove size and everything ready, so that the provider comes in and immediately does what he or she needs to do. So we often stressed on that kind of aspects because of those challenges in these level 1 and other rural settings. Another thing that we did was we always brought in all the teams, including unit clerks, people from personnel from the EDs. They would all come for the simulation, but it is not very common for us to get OB providers or even anesthesiologists to come for our simulations. So I want to show you our ED sims. So we went and did simulations in hospital ED hospital bays, EMS and transports, and fire stations. So we've delivered in the back of ambulances, and you can see this is in a fire station. So this person you can see right here with the mustache, he's a big burly guy, and when we first walked in there, he said, "I'm not gonna be doing any one of these things," and he just went away. And we were there the whole day doing simulations, and by the time the evening rolled around, he came back and said, I think I want to try this. I want to do a delivery. I said, okay, go ahead, do it. And then the next time around, I said, no, I don't want you to touch. I want to do it all by myself. So these are these huge hunk of a guy who first said, I don't want to have anything to do with simulation, but came around and then did it. I also have a really cool picture of me in the back of the rig, but I'm going to spare you that, and instead, I put this other one. If you can see in the corner there, can you see all the boots and the trousers and the jackets and the hats? So when there's an emergency, the firefighters would come in, they would go into the booths, they'd pull up their trousers, put on their jackets, put their cap on, and then they go out. And so much of preparedness. I thought that was just fantastic. I felt very honored to be able to go to their domain and to be able to share what I knew with them, and they shared what they knew with us. And it's truly a privilege to serve these folks who look after us at other times. So this is our reach, and I can very proudly say that I have really traveled to every corner of my state and it's actually even more lines now because this was from last year. We do a tremendous service in going to every part of the state. And as I said, the information we give is always the ones that's up to date, and it's the standard of care, and it is the same standard right throughout the state. So sustainability and where we are today. So now we are in our second Maternal Health Innovation Grant, and earlier we had an Iowa Maternal Quality Care Collaborative, but now it is a PQC, it's a Perinatal Quality Care Collaborative. We have consolidated our AIM coaching and our simulation team, so we don't have a separate simulation team now, but we have both together, so the coaches are also the simulation experts. And that makes for a lot of common sense because the coaches go in there and they see what the challenges are, and then they do the simulation, and then they can follow up on it. So that just makes total sense. And now that we have done most of the both of the key bundles, we also offer simulation from a sort of like a menu. If a facility has had a challenge, then they can always tell us, okay, hey, we want to, do a sim on this particular, maybe it could be a cardiac arrest or an anaphylaxis, and then we would, create that simulation for them, and then they would be able to run it. So recently, we are collaborating with Sim Iowa, and Sim Iowa is another simulation program that's right throughout the state, and it's run by the College of Nursing at the University of Iowa, and it's through a Wellmark grant. And just last Thursday, we went and we had our initial meeting, and you can see that Sim Iowa has these big trucks, and they actually not only take simulation equipment, they take the simulation space also when they travel. And there are 3 trucks that are spaced right throughout the state. So we will be collaborating with them and that's very specifically to go to the maternal deserts. So those are the hospitals where there's only an ED, but there is no OB unit. So I really speeded things up, so hopefully you got all caught up with time. Whenever I go for these simulation visits, I'm often asked, okay, so I introduce myself and I say I'm an anesthesiologist. And when I say that, and people will ask me, okay, so you're an anesthesiologist, so what are you doing here with these OB stuff? And then I tell them, yeah, well, do you do your anesthesia stuff? Do you do stuff in the OR? And I said, yeah, I'm an OB anesthesiologist. I'm 100% clinical. I practice anesthesia all the time. But you all would be surprised that us anesthesiologists, we have a lot of other talents. We are very skilled. You know, we do simulation. And, you know, I'm probably speaking to the choir here because patient safety is something that we are leading in. And there's so many aspects that we do. We are leaders. And this whole program, I put it together. Quite a lot of it was my creation. And it is my skill as an anesthesiologist, I think, that has reflected on other skills that I have developed. So I'm going to put this next slide up. And as I said, I may be preaching to the choir, so forgive me if I'm doing that. But I want to reflect on what specific skills or expertise that we have as anesthesiologists that can bring about and help bring about practical and sustainable solutions, not only to improve maternal care, but to do improvements in so many other aspects that we talked about. And today we talked about so many of those skills that we all have. And as I said, you know, I always want to bring myself out of the OR. I think we are all fantastic in the OR, but we do also fantastic things outside of the OR, within our community, within our state, within the whole country. And I think the key problem now is, you know, how do we get this message out of this room? We all know this, but we need to tell this to the rest of our anesthesia community. So that's the question that I would like to leave you all with for self-reflection and see how can we get this message to all our anesthesia colleagues that we've got so much more skill. We are fantastic in the OR, but we are fantastic outside as well. Thank you very much.
Thank you very much. An absolute pleasure to be here. I want to talk about checklists for obstetrical emergencies. And just to get the glossary part out of the way, I generally use the terms checklist, emergency manuals, cognitive aids, pretty much interchangeably. But just to be crystal clear, what I'm talking about are tools designed for the real-time support of clinical management, secondarily as training tools or a matrix for case review. I'm not talking about textbooks, practice guidelines, review articles, or other things, but they generally supply the content for the checklist that I'm going to discuss. For those of you who attended the 2015 APSF Consensus Conference, this may be repetitive depending on how intact your memory is. But just to put a little context around today's topic, it is traditional in discussing checklists in medicine to spend some time self-flagellating a little bit about how far behind healthcare has been to other industries like aviation and nuclear power. And generally that's true, but I must note that in 1924, a Philadelphia surgeon published in Anesthesia and Analgesia, if you can believe it, advocating that a checklist be posted on the wall of every operating room to guide the resuscitation of patients having arrest during operation. He was generally ignored, obviously, and it took 75 or 80 years for us to catch up. I want to point out among these efforts in the area of cognitive aids in healthcare, 3 in particular. Peter Pronovo's Michigan Keystone Central Line Infection Project in 2006. A complete coincidence that a photo of Peter is on your table, and the only thing I'll say about that photo is that it's at least 20 years old, or I want to know what he's taking. And then Atul Gawande's work on the WHO Safe Surgery Checklist, and Alex Arriaga's paper on the operating room crisis checklist. All three of these were lead papers in the New England Journal of Medicine. And I think it would be fair to say that the publication of those projects and their rather stunning results softened up healthcare, so to speak, to the use of cognitive aids. And you'll notice when you look at this list that a number of them are designed for what in aviation they would say would be routine operations, that is standard procedure, every case, every time. And there are others, like the ones we're going to focus on today, that are for non-routine operations when the you-know-what hits the fan. So I don't need to tell anybody who has managed one of these dire emergencies of why there's a need for checklists, but I will. That is that these are high-stress events, and they are rare. And the combination means that you cannot rely on memory to effectively guide the administration of the key steps of management. Unless you're really unlucky, you have not managed a case of amniotic fluid embolism in recent memory. And so trying at 2 in the morning when you realize that you have a patient slipping away from you to rely on cognitive function to guide care is foolhardy. And it's not only the clinical care of the patient, but you need to be managing that team and creating a shared mental model. And it's always amusing to me the fact that we often use the expression on the same page to describe the shared mental model. And in a minute, we're going to be looking at exactly what that page looks like. And in many settings, that page is actually projected on the wall. So just to take one of those three projects that I mentioned and take a second to say the concept of the value of a cognitive aid in a critical event has been demonstrated over and over again, but again, probably because of the prominence of the publication, the work that Alex Arriaga, by the way, a research fellow at Ariadne Labs at the time, published in the New England Journal, showed a 75% reduction in the omission of critical steps. So these are simulated critical events, about 5 different events, and if I remember correctly, they identified 47 can't miss steps in the management of that group of crises, and this is what was seen. So just overwhelming evidence that experienced clinicians performance improved dramatically with the use of these tools. As my colleague Bill Berry, who was very involved in that project, says, no big surprise there. If you take a test and you're given the answer sheet, you're going to do better. I won't spend much time on this, but last year or the year before, a systematic review asking this very question, do these work, was published. And as you can see here, the answer was resoundingly yes. And one of the things that tickles me a little bit is that if you look at the aggregate difference in performance in the studied surveys, they are right where Arriaga was, 75% reduction in omissions. Now, so you may be familiar with the operating room crisis checklists that are in relatively common use, not as pervasive or uniform as the WHO checklist, but Stanford has done amazing work in this area. The one in the middle is the latest version of our compendium from Ariadne, and the electronic version of the Society of Pediatric Anesthesia PD crisis is shown there as well. So what does all this mean about maternal mortality and obstetrical emergencies? You've heard about the various causes. I don't have anything to add to that discussion, except to say that when you think about eliminating harm from those disease entities, think about it in 3 buckets. Prevention. We heard a little bit, much less than I expected actually, about prenatal care, but that is a big part of it. Recognition of the development of the event and intervention. And this is where the intervention is the focus of the tools that I'm going to discuss. And I think of that as the last and best chance to save a life. When one of those disease entities flares and becomes life-threatening, what are you going to do, and what can you do to assure that you're doing the very best job you possibly can for the patient based on what we've learned from operating room events? So I'm going to deviate a little bit and tell you my personal story about obstetrical checklists. So before I left Newton Wellesley Hospital about 2016, 2017, it's a well-to-do suburban community hospital that is part of the, now part of the MGB teaching network. But I introduced the operating room crisis checklist there. And consequently, many of our obstetricians were exposed to the OR crisis checklist, both in actual clinical care, but also in obstetrical team training simulations. And over again, they came to me and said, wow, there's so many obstetrical events that lend themselves to these kinds of tools like you use for cardiac arrest and anaphylaxis and air embolism in the operating. Wow, it would be great if we had them. So my response was, well, you know much more about a lot of those obstetrical emergencies than I do, but I've learned something about construction of checklists along the way, and maybe we should get together. And one of the activities from my almost 30 years at Newton Wellesley, of which I'm most proud, was the volunteer effort among a bunch of private practice obstetricians, midwives, labor nurses, MFMs. We met every 2 weeks for about 5 or 6 months and drafted and redrafted and revised what turned out to be a compendium of 17 obstetrician-driven crisis checklists. And a few months after we finished that, I got a call from a buddy at Kaiser Permanente named Paul Preston, who has been at this conference many years. Said, do you know anything about checklists for obstetrics, as we're putting together a task force at Kaiser to develop them? So I said, yeah, as a matter of fact, we just implemented them, and we put them in the on-call rooms and the labor rooms and so forth. He said, would you share it? Absolutely. So a couple of weeks later, Tul Gawande comes up to me and says, I just spoke to about 15,000 staff at Kaiser Permanente, and all they wanted to talk about was OB checklists. And said, was that you? And they disbanded their team, their task force, and adopted and adapted the Newton Wellesley checklist across 15 or 16 Kaiser hospitals. And the interesting thing about that is those hospitals were very different from one another. And so that's where the importance of the adaptation comes up. And then along the way, I heard that somebody had implemented them at Jefferson and in Dominican Republic and the University of North Carolina. And I realized there was an opportunity there. We have a private community hospital, mine, a university medical center, and a health system group of hospitals all doing the same thing. What was the experience and what could we learn about it? So we did a mixed methods study of the implementers at those institutions and published it. And I'll get to the punchline at the end. But last year, I became aware that all of those institutions had recently done revisions and updates, and also the Obstetric Anesthetists Association in the UK had developed developed the OB crisis checklist as well. So what has everybody learned in almost 10 years of use of these crisis checklists? And wouldn't it be great to compare notes and find out why they changed whatever they changed? And is there possibly a best of breed that we could produce as sort of a generic version to put out there for free, as we have done with all of the other work products at Ariadne? Not something for the 30-bed critical access hospital, and not something for Massachusetts General, but someplace in between. And we had recently developed a editing and modification tool for the OR crisis checklist, and why not adapt that? So that is the project that in the current funding environment is frankly stalled a little bit, but that is our vision to be able to bring that forward. This is a recent version of the Newton-Wellesley crisis checklist, and we make it available through the emergency manuals webpage, along with a whole bunch of tools and an implementation toolkit. I apologize, I checked, and the one that's on that website is the prior version, so I am currently hounding my friends at Newton-Wellesley to get us the very latest to replace for the website. But in any event, you can look and touch and feel and smell what we've done. One thing that we did with the OR crisis checklist that I think is relevant to this work as well. Here's a page from that compendium of checklists. If you hold this up against the 1935 B-17 aircraft checklist, you'll notice right away that the look and feel and the user-centered design has carried forward to modern-day aviation checklists, but also this. The font, the spacing, the use of color, et cetera. We have done everything we can to learn as much from NASA, from Boeing, and other people with decades of experience in using similar tools to make them maximally effective when we need them most. The other thing, as I was about to say, is that in the OR crisis checklist, the most recent version, we tapped into some work that, again, Alex Arriaga led, and I believe this was a FAIR APSF grant-funded project to address the challenge that if I asked you, should you debrief after an OR critical event, you'd probably all say yes. And if I asked you, well, what does that look like? What are the steps to do it in a psychologically safe way to do more good than harm? It would be challenging. And the fact that that challenge exists in this study turned out to be a major barrier to it actually happening. So we have created a concise outline for a critical event real-time debriefing that is the last page in the new version of the OR crisis checklist, and intend to make it part of the obstetrical crisis checklist as well. Just a word, and I'm just about done, to address the matter of healthcare disparities. And a couple of prior speakers have spoken to the problems in the obstetrical deserts, the low-volume rural facilities, and I would add the safety net hospitals where there are special reasons to deploy tools like this. I said at the beginning, why do you need crisis checklists? Because these events are rare and you haven't had recent experience. Well, if you're in an emergency room in a hospital without an OB unit, or in an OB unit with 200 deliveries a year, your experience is even more rare with these things. You don't get to simulate or train. You don't have anybody to ask for help. So where could the need be more acute than in those kinds of settings. So there's a special need, and the connection between the rarity of the event and the importance of support is my argument why it's not just the 50% of obstetrical severe morbidity and mortality being hemorrhage. Yes, cognitive aids help in the management of that, but the more rare the events, the more compelling the argument for the availability of cognitive aids becomes, in my opinion. And let me, before I close, just acknowledge the fact that the use of these tools is a cultural change, and cultural change ain't easy and takes time. And we've thought a lot about it and had a lot of experience with doing that, and you've heard some expert speakers about how to make that happen. We like to say that these tools have value and can be embraced and used effectively in the presence of one critical ingredient, and that is humility. That is, clinicians need to be able to accept the fact that they could miss something. And this is not just for us to internalize, but we need to share that with those around us so that when you pull out the checklist, the reaction is, oh, that guy must be a complete moron if he needs to refer to a checklist. No, that's best practice. So let's try to get there, and thank you for your attention, and I guess I didn't do too badly.
Thanks, everyone. It was really a jam-packed day. I want to give permission for everyone to go rest, refresh, reflect on what we've talked about today. And I think there's a focus group happening, right?
Yep, if you're interested in the focus group, you can talk to Stacy in the back. Otherwise, we'll see you at the reception. Feel free to mingle, ask questions. The last mile happens tomorrow. So we need you all to be there and present and excited and engaged tomorrow, because that's when we figure out how to actually do the things that we talked about today. Thank you, everybody. Have a great night.